Okay. I think just to welcome everyone, to welcome, of course, all the attendees, to welcome all the experts, moderators, and of course, I want to thank them to be with us. So we will have a very nice meeting, of course, a virtual meeting, but nice meeting because we are going to speak about normal anatomies with EUS and how to get all the images. We will have a session about EUS staging for biliary carcinoma and pancreatic carcinoma, and we will have two sessions about therapeutic EUS. You know, it's growing field for EUS, and we will have some lecture about vascular intervention, about biliary intervention, pancreatic ductal intervention, and also LAMS intervention. So thanks again to be with us, and I think we are going to start with the first lecture, and the first lecture is coming from Professor Kangonen, and this EUS imaging of mediastinal lymph nodes. So, if you can start.
Yeah, I'm starting. And I think you can see me and hear me well, I hope.
Yeah, we can see you.
Yeah, okay. Welcome.
Again, thank you to be with us, and again, thank you for your coming lecture.
Yeah. Welcome to everyone from Istanbul, Turkey. This is Dr. Can Gönen, and I wish a wonderful and successful meeting to all participants. And also I would like to thank the organizing committee for the kind invitation. My task today is EUS imaging of mediastinal lymph nodes. And the task is like this. I'll try to talk about linear EUS imaging of mediastinum and indications for mediastinal sampling. And if time left, I'll talk about radial EUS imaging of mediastinum, which we are using less and less today. And before starting, in most part of the world, the direction of the patient's head shown on the right side of the screen, and some parts of the world using the reverse. So I will, during all the lecture, I will use as the head or the oral side of the patient's see on the right side of the screen, and you can always change it by pressing the invert button. And all the mediastinal stations which we talk about today rely on this mountain and Dresser mediastinal map as shown here. With EUS, we can easily observe areas of peri-esophageal station 8 areas, subcarinal station 7, 4L, 4R, and station 2. If we use endobronchial ultrasound, we can easily look in lymph node areas of 10, 11, and 12, in other words, the hilar area. And to begin, the station 7, the subcarinal lymph nodes, this is the area between the left atrium and the pulmonary artery. To find this area, the best way is first to go into the stomach, find the hepatic vein, and follow it until it falls into vena cava. And then, following vena cava, we will reach right atrium. And if we throw the scope 1 centimeter next to right atrium is, of course, the left atrium as shown here. This area is the most important area for us. This is the left atrium, this is the pulmonary artery, and this is the station 7 region. And also, to become familiar, if you look at, we also see the left ventricle, the mitral valve, the aortic root, and the aorta itself. So you do not need to memorize standard centimeters to find left atrium, like 44 or 45 centimeters. The easiest way is go into stoma, find the hepatic veins, and follow it. By this way, by following landmark structures, you can always find the structures what we are dealing with. And let's look at this area in detail. Yeah, this is the left atrium, this is the aorta. If we see aorta in longitudinal section, we always see pulmonary artery in transverse section. In other words, here, the aorta in longitudinal, pulmonary artery in cross-sectional. If we talk and if we see pulmonary artery in longitudinal section, we always see root of aorta at the cross-sectional level. And the area between the pulmonary artery, indeed right pulmonary artery, and the left atrium is the station 7 region. Okay. Yeah, here is it. This is pulmonary artery longitudinal, and the aortic root, the left ventricle, and the left atrium. And sometimes we see left coronary artery also. I will show in this video. Yeah, look at this structure here. This is the left coronary artery. Yeah, you can see it, I think, and it comes to the left sinus of the aortic root. And sometimes we see just ostium of the right coronary. Here is it. This is the ostium of the right coronary, and you can also see a plaque in this patient. And this is the aorta, for sure. And for station 4L and 5, indeed 4L is the area between pulmonary artery, aorta, and station 5 is indeed next to the ligamentum arteriosum, and station 6, the para-aortic region. Now we are here in the map, and how to find station 4? Indeed, when you observe station 7, if you withdraw the scope while rotating counterclockwise, you will reach the area of interest. In other words, station 4L, this is the area between aorta and the pulmonary artery. And finding for R, what should we do? We have to turn 180 degrees from 4L position, and then we will see the azygos vein here, and also the renovation artifacts of the trachea. If you look in detail, this is the area between the azygos, trachea, and this is the area where azygos drains into vena cava. This area is the station 4R region. And station 8, this is the periesophageal region. And to examine this area, you had to be a little bit slow, and you had to turn 180 degrees in a clockwise fashion, and then you had to come to the neutral position and then rotate 180 degrees towards the other side. And you had to do it by withdrawing scope nearly 2 to 4 centimeters. This is the periesophageal region. And the station 2, it is the upper part where we observe branches coming from the aorta, like artery, and also we can also see thyroid gland. Indeed, many times it's more easy during the head to see the thyroid gland. And sometimes we itself see the tumor itself and we can biopsy. And the most important part is, do not forget these structures under the diaphragm. So the celiac region and the left adrenal gland and the liver, of course. Here we can see an hemangioma, an incidental finding in the cancer patient. And to see celiac lymph nodes, and when you observe liver, you have to rotate the scope clockwise to see the abdominal aorta. Let's look at it in view. Here is it. This is the aorta, this is the celiac, and this is the superior mesenteric artery. Okay, left adrenal gland. It seems like a seagull, as shown here. it is next to celiac, you have to rotate echo endoscopy to see the structure. Let's see it. Yeah. Okay. Here, this is the aorta and celiac artery. If you rotate the scope, yeah, you see the left adrenal gland and also the left kidney here. Here in this patient, there is a, here you see a mass in the left adrenal. Indeed, this was a cancer patient, but this was a benign incidentaloma. So, especially for non-small cell lung cancer staging, you have to examine all these areas: 4R, 4L, 7, liver, aorta, in other words, the celiac region, the left adrenal gland. So, about sampling indications, if we have a non-small cell lung cancer with abnormal mediastinal during CT or positron emission tomography, you have to take biopsies because there is risk of false positivity rate with these imaging methods. So this is the main indication. And the other indication is if there is no abnormality at CT or at CT path, you always think to sample these mediastinal lymph nodes if the tumor is more than 3 centimeters, if the tumor is FDG avid, if there is no activity, or if there is ipsilateral lymph node, hilar lymph nodes are positive. And the other indication is for centrally located tumors, and also after neoadjuvant treatment. These are the general rules for non-small cell lung cancer. And the order of biopsies: first you have to biopsy the distant metastasis, and then the contralateral lymph nodes, and then the ipsilateral mediastinal, plus the hilar lymph nodes and the tumor itself. And this is shown in this graphic drawn by Professor Clemenza. And the other indication is lymphadenopathy of unknown origin. Of course, EUS guided biopsy is the preferred approach for this purpose. The second line approach are CT guided biopsies, but there is a risk of pneumothorax, of course, and mediastinoscopy is invasive. So some samples. The first one is sarcoidosis, and there are some suggestive features. Of course, not pathognomonic. Always you need biopsy, but if there is symmetrically distributed lymph node clusters around big vessels, or if there is granular or sandpaper appearance of distinct margins in a suitable clinical context, you can always think sarcoidosis, of course. And when compared to blind bronchoscopic transbronchial biopsies, EUS or EUS guided sampling is clearly superior, especially in early stages. And the other diseases, tuberculosis, some suggestive features, of course. These can be hyperechoic foci, which we call it as stereoskine sign. It is due to necrotic debris, calcification, or in cases of fistula because of air, indeed. And you can sometimes see necrotic areas here as hypoechoic areas inside the lymph nodes. And these lymph nodes can be discrete or confluent, borders, and sometimes they fuse. And what is interesting is station 7 involvement is commonly reported. Lymphoma diagnosis, it's a little bit problematic because diagnosis is okay, seems good, but subclassification is especially difficult for Hodgkin, for T-cell lymphomas, and for grading of follicular lymphoma. Always think about additional ancillary studies like immunohistochemistry, and always think about adding flow stometry from the samples. And esophageal cancer, there's so much discussion. It's very good for T-staging, and especially in T1 cases for excluding lymph nodes. Always be careful not to traverse the tumor if you're gonna take biopsy. And which lymph nodes had to be sampled? There are features suggestive of benign lymph nodes. They generally tend to be triangular in shape, and there's generally a central echogenicity. And if you are using elastography, as shown here, it's green. What about the malignant features? They're generally round shape, has a round shape, no echogenicity, hypoechoic pattern, and size, of course, in general, more than 10. And if you are using elastography, as shown here, it is blue, or in other words, it is hard. These features are most useful to choose which lymph node for sampling. Do not rely just on EUS features of lymph nodes for decision. Of course, the tissue is the issue. And some words about sampling. And the most important thing is the fanning technique, I think, which is shown here, to take biopsies from different parts of the lymph node. And also the needle size. There are so much studies, although 25 gauge needles are a little bit superior for pancreatic cancers. For the mediastinal lesions, there is no superiority of one needle to other, with very prominent difference. So what we can say is 20 gauge is, I think, the in general the current standard. If you are taking biopsies from lymph nodes, or you don't need to use section, and you don't need to use stylet every time. And what is important is transesophageal EUS guided sampling of cystic mediastinal lesions should be avoided due to high risk of infection. Of course, in some selected cases, if the case is suspicious, if you have no diagnosis, sometimes you have to take biopsy, but always think antibiotic prophylaxis. But the general rule is do not take biopsies from the mediastinal cystic lesions. And a few words about the radial imaging. Again, the best way is to begin the examination in the stomach to find the liver in the aorta. And when you end, it's somewhat more easy because the EUS images correlate with a CT scan. They're cross-sectional images. What is important is to avoid tangential imaging because esophagus is tortuous and the scope is rigid. So you always have to follow the contours of the esophageal wall with up and down and right-left knobs. And also the other thing, you have to rotate the scope, that the aorta should be at this 5 o'clock. As shown here, and spine at 7 o'clock. And when you withdraw from stomach into the esophagus, you can clearly see the aorta and spine, of course. If you withdraw, this area is indeed the station 7, or in other words, the periesophageal region. And if you withdraw slowly, then you will see left atrium at 10 to 12 o'clock position. And again, with slow withdrawal, you can see the right and left main bronchi, and the area just between these bronchi is the subcarinal region, or in other words, station 7. And from station 7, if you withdraw slowly, then you can reach, you will see the tracheal renervations, the azygos in longitudinal section, and spine. And the area, just a centimeter above, is the area of aorticopulmonary window, which you see just under the arc of aorta. And this is the station 4L and 5. And when you come upwards, you will see the station 2. And also you can able to see the thyroid, and when you see the cricoid cartilage, it means that you totally examine the wall esophagus from gastroesophageal junction to the upper part of the esophagus. Some other pathologies commonly found in different locations are shown here. What are important are as I mentioned, bronchogenic cyst starting and the duplication cyst, which we do not have to sample, and some other lesions. I will not talk about the subepithelial lesions of the esophagus because of time limitations. And I would like to thank you, and I think I finished my talk at the proper time. We will discuss in the discussion session. Thank you.
Okay, so thank you very much. I think it was one of the most helpful lecture I ever heard about mediastinum and FNA or FNB of lymph nodes. So thank you again. It was a very, very nice lecture. So we will have a common discussion thereafter the lecture of Pierre Eisendrath. And so we will have, I think, a lot of questions by chat. So again, thank you very much. So Pierre, are you with us?
Yes, I am. Are you?
Okay, nice to hear you.
Good afternoon. Good afternoon, dear colleagues. Good afternoon, Dr. Pierre. First of all, I would like to thank you, organizing committee. This meeting really is so important these days. I hope we can hold face-to-face meetings, workshops soon. Now we move on the second speaker. He is Dr. Pierre Eisendrath. He is from University Libre de Brussels in Belgium. He talks about pancreas normality, anatomy. Welcome to please, Dr. Pierre.
Thank you for the invitation.
Pierre, just before, I just want to introduce the moderator because it's sometimes a little bit difficult with virtual presentation. So the woman who was speaking is Dilek August. So thank you, Dilek, to be with us. I think we have also with us Anna Koslowska. Anna?
Hello,
Yes.
hello.
Okay, Anna, nice to hear you.
Hello.
And normally we have Professor Rajkumar Wadhwa. I don't know if, no? Okay, so Dilek and
here.
Anna, yes, we are with us, okay. Thank you, Rajkumar.
Thank you, sir.
Thank you, sir. So I let the moderator doing the moderation, and Pierre, I just want to congratulate you and to thank you to be with us. And now I close my mouth. So thank you.
Should I start?
Okay.
Hello. Hello
Yes,
to everyone,
yes,
and thanks for these nice words. And hello to you, Mark, also. It's nice to see you, even if it's virtually. So it's again my pleasure to participate to this Congress. And my task now is to share with you my view on the pancreatic normal anatomy. And I have to tell to the audience that for sure, this is a basic view for the beginners in EUS Pancreatic EUS. For the expert, you feel free to stay with us, but for sure, most of the experts will know what I will say. So the aim of this talk is also to speak about what's learning, and for sure there's a lot of way to learn, and books, didactic course like this one, and also simulator, hands-on training video. All these stuffs may be used to access some kind of knowledge to do EUS. But from my point of view, the most important one is the fellowship, and I would urge the beginners to go for having a fellowship, even in their hospital or the university or abroad. And again, the length of this fellowship will depend also of the case volume you can be faced on, and this may depend on the centers. But what's known and what was released already 20 years ago, that there is a number number of cases to be exposed to acquire this competency. It was settled by the ESG 20 years ago, and also the ESG had some words about that. But we have also to remind us that these numbers may be a bit underestimated when you see some last released in 2015, for example, in one of the European journal, which shown that these numbers were underestimated when you see the numbers of cases that the beginners have to be exposed to acquire these competencies. So keep that in mind if you are looking for centers to be trained. Concerning the choice of the scope to do a pancreatic examination, you know certainly that the two kinds of scopes, the linear and the radial scopes. And if the linear scope gives some disadvantage, like the most difficult perception of the image compared to the radial scope, which is a 360-degree views, and which is probably more comparable to the image that you are used to see, like the CT scan or the MRI. And also, if this scope is a little bit more invasive and can be a bit more dangerous, which is not proved, but that's my feeling, certainly, and for sure, the linear scope gives us the advantage of giving the ability of making a FNA, which is quite important in the pancreatic examination. It gives you also this slide forward view scope. Most of the company gives this slide forward EUS image, which helps you to progress and to feel the progression of the scope without having doing an insufflation. And also, and I'm quite confident in that, I'm quite sure of that the linear scope gives you a better view of the pancreatic parenchyma. And that was almost proved by one paper in 2015 comparing the small anomaly in high-risk patient of pancreatic adenocarcinoma. And clearly the linear scope gives you a better identifying of these lesions compared to radial examination in a cross designed study. So there are no recommendations in the guidelines, but clearly there are no sampling with the radial scope, and this is my personal preference for using a linear scope in this indication. And that's why all the video I will show you will be with the linear scope. Some words about the pre-examination requisite. And a particular word concerning the risk of bleeding and the importance of having the ENR less than 1.5 and platelets over 50,000, and are send you back to the guidelines released by the ESG that you can find in the website of the ESG concerning the use of the anticoagulation or antiplatelets medication. Again, no need for antibiotic prophylaxis in most of the indication, except maybe for the cystic lesion in the pancreas. And as it was said by the previous speaker, no indication of making a puncture in the mediastinal cyst. But going back to the pancreas, to reach the region we will discuss, I would urge you to progress mainly on EUS forward view. With the linear scope, it's more easy, I told you before, and without avoiding insufflation of too much air. Natural position will depend on the position of the patient, and in my clinics, I most of the time put my patient on the left side position, but you may encounter some situation when the patient is on the back, and then you have to turn yourself a bit to expose more classically your scope. And the most important movement to acquire it is the rotation of the scope around the axis, and counterclockwise and clockwise rotation will be probably the word I will most use in the next video I will show you. Just a reminder also, it was also said by the previous speaker, that for oncological indication, you have to think the reverse of the TNM's classification. You have to think MNT, first looking for the metastasis, then nodes, and then tumor, certainly when you are speaking about doing FNA. So going really in the deep of the subject, for the pancreas, there are three stations, as you know, the gastric station, the bulbous station, and the duodenal station. And we will start with the gastric station in this presentation. I will turn this schema to make the presentation more clear. And generally, you will find the pancreas between 40 and 50 centimeters from the dental arch. And as I told it before, the most important movement will be going clockwise or counterclockwise here, or clockwise. And this structure from this situation, maybe from this position, will be able to be explored, going from the liver to the spleen and crossing the pancreatic body and the pancreatic tail when you do a clockwise rotation, and the reverse if you go counterclockwise. But most of the time for the beginners, the difficulty is to find the pancreas, which may sometimes be difficult, particularly in the case of atrophy of the body of the pancreas and the tail. And so the two next slides will be on how to find the pancreas. The first way to do it, it's to find firstly the liver, which is more easy because it's a bigger organ. And this is generally by turning your scope counterclockwise on the right side of the patient. When doing that, it's quite easy to find the ileum of the liver, and from the ileum, you will have to follow the portal vein. And what is interesting is that when you follow the portal vein and you find the confluence, the only organ that you can find between your scope and the gastric wall and the confluence will be the pancreas, whatever the situation, even in heavy atrophy of the pancreas. So by finding the liver and going back in the clockwise rotation, following the portal vein, you will find this organ. It's what I will show here. I go back with the video from the start. So I am in the liver. I find the left liver lobe. I identify the portal vein over there. And just by turning clockwise from there and pushing my scope, I'm able to follow the portal vein up to the confluence. And in this situation, for sure, it's quite obvious because it's a large pancreas, but between my probe and the confluence, you can see the pancreatic body from the isthmus part and the main pancreatic duct. The other way to find the pancreas, which is more classically taught and maybe more easy, but only if the pancreas is not atrophic, it's to push the scope from the celiac trunk and to cross the two splenic vessels. That will be illustrated in the next video. Again, I will put my video on the beginning. This is the aorta and the celiac trunk. I will have just to push my scope forward, cross the two splenic vessels, the splenic artery and the splenic vein, and finding the pancreas, the main pancreatic duct. From there, it's quite easy to pursue my examination of the pancreas by just turning clockwise my scope and following the main pancreatic duct up to the tail. This will be illustrated in this patient. So I just turning clockwise, sometimes having to retract a bit my scope because some pancreas are more vertical than other. And I can reach, still turning my scope clockwise, the splenic ileum and the splenic vessel. This is the pancreatic tail, or really the end of the pancreas. Again, from there, if I'm going counterclockwise, and it was shown before by the previous speaker, I can find the kidney, and I can also identify the adrenal gland, which was much more explored and much more illustrated by the previous speaker. Okay, so in one, if you look to the liver, in one movement, I can go from the ileum of the liver, following the portal vein, up to the confluence, and there identifying the pancreas from the isthmus to the body, up to the tail. All that in one movement, clockwise rotation. This was the gastric station. The second station is the bulbar station, which sometimes is more difficult to acquire for beginners. But again, it's a word about turning clockwise and counterclockwise the scope. And from that position, if I'm turning clockwise, I will be, depending on the insertion of my scope, I will be able to follow structure going from the pancreatic neck to the papilla if I'm staying next to the pylorus on the pancreatic side, and if I'm pushing my scope a bit further to be able to follow the biliary duct from the common bile duct to the papilla. So in this illustration, I will be only limiting my video on the pancreatic view. So I'm much more positioning my scope just after the pylorus, sometimes even before the pylorus, depending on the patient. So again, I put my video on the beginning. I'm situated in the bulb just next to the pylorus, and I'm able to identify the confluence. And again, in this situation again, the anatomy or the structure which is in between my probe and the confluence, it's the pancreatic parenchyma at the level of the isthmus, sometimes defined by some author by the pancreatic parenchyma between the duodenal artery and the confluence. This is the main pancreatic duct. And I will turn my scope clockwise up to the papilla with the command bile duct merging with the main duct, the main pancreatic duct up to the papilla. This is illustrated also in this second video, where you will see the confluence. Here in this video, in this anatomy, we see already the command bile duct in the pancreatic parenchyma. This is the main pancreatic duct. We are at the level of the isthmus. And by turning the scope clockwise again, I see the merging of these two ducts up to the papilla with the duodenal wall here, and this is the papilla structure. Just a word about the hypoechoic aspect of the parenchyma surrounding the papilla, which is totally normal, which is embryogenic situation with this more hypoechoic aspect, which is not a tumor. From that position again, I can go counterclockwise, go back by following the main pancreatic duct, go back to the confluence. And I just want to illustrate in this patient a nice confluence between the dorsal duct, which is dividing into the main pancreatic duct, and the Santorini, which can be followed again by a clockwise movement. So I go back to the papilla, but not the main papilla. I will go. This movement will follow the Santorini duct up to the minor papilla. Just a word about the anatomy. In some patients, we know by the anatomical series that a patient may have the main pancreatic, the common bile duct, outside the pancreas at the level of the head. This is at least in between 50 to 20% of the patient, which may show you an aspect of the common bile duct going outside from the pancreatic parenchyma. But this is just anatomical variation. The last station is the duodenal station. In that station, you will have to push your scope into the second or even the third duodenum. It has to be done at the beginning with a mentor because it's probably the most dangerous progression of the scope with the most highly risk of perforation with this tip of the echo endoscope. So do it with cautious. And having retract your scope from the gastric loop, the end of your scope will be positioning just in front of the uncinate process. And the thing I would like to share with you is that in that position, when you turn your scope clockwise, you are positioned in a more secure position. You have a less risk to be expulsed in the gastric lumen. If you turn your scope counterclockwise, you will be more able to see the papilla part of the cephalic part of the pancreas, but you have a higher risk to be expelled into the gastric lumen. So by small retraction, I will try to identify all these steps, going from the uncinate process up to the papilla and looking to the two ducts which are merging to the papilla. This is illustrated in this video. So this position is the more deepest position where you are able to identify the two mesenteric vessels. First, the superior mesenteric vein, and here in the back, the superior mesenteric artery. It's usual to have the vein more close to the probe and the artery more in the deep. And by turning clockwise, I can expose the uncinate process. And if I turn in counterclockwise, I move to the papilla, which is not visible in this video, but we follow the progression. I retract my scope, and then I can visualize this more hypoechoic aspect of the parenchyma, which is surrounding the papilla. And you can see here the main pancreatic duct. And the next step is to expose the common bile duct, which is over there. So this is all the ad, and this is the end of the third station. But from there, you can follow the main pancreatic duct up to the isthmus and go back into the gastric lumen to see the body and the tail of the pancreas. So what to do? Do we have to start with the gastric station or the duodenal station? So there are no recommendations about that, but starting from the second duodenum offer you the advantage of expose the whole pancreas in one movement examination, which I didn't show you in the video, but you can understand that you can start from the duodenum and look to the gastric station after and having an whole exposure of the pancreas. However, starting with the gastric station is probably easiest for beginners and less dangerous, probably. It's offer you in some patients a complete examination of the pancreas because you can see the pancreatic head from the gastric station in some patients. I didn't show you that, but it's a situation which is not rare. And also it helps you to spotting the aspect of the pancreatic parenchyma, which is more easy in the gastric station, to my point of view, to identify that, to identify it from the bulb of the duodenal station. And finally, it's also adapted to alternate anatomy, which is also important to acquire. So I would prefer to teach first to my fellow the gastric station before to start with more difficult station, which is the second and the bulb. Just some word about pathology. This is the aspect of the pancreatic adenocarcinoma. You see the hypoechoic structure into at the level of the pancreatic parenchyma, which is involving all the vessel and infiltrating surrounding the vessel. This is also an aspect when you start from the celiac trunk, you push your scope. So you are in the gastric station, you push your scope, and you will find the pancreatic body, but which is obscured by a hypoechoic mass. And here the aspect of the neuroendocrine tumor, which is hypoechoic structure with clear border, which is found in the posterior part of the body of the pancreas. You see again here the splenic vessel. Sorry, I passed too quickly on a cystic aspect here, a typical cystic aspect of IPMN, a branch duct IPMN, with the main pancreatic duct here, and the aspect of this cystic structure, confluent cystic structure with incomplete septa. And finally, because I'm almost at the end of my time, this is the aspect of chronic pancreatitis, calcifying chronic pancreatitis, was in the main pancreatic duct at the level of the papilla, with the main pancreatic duct here, hyperechoic structure with shadowing in between, in behind, which is typical of a calcifying structure into the duct, which is typical of a chronic calcifying pancreatitis. I thank you for your attention, and I urge you, if you want, to come to join us in Brussels next June.
So thank you. Now it's to the moderator to speak and to ask some questions if they have.
Hello, thank you very much. It's a big pleasure for me to have opportunity to take a part in the conference, to meet with you in the air. And congratulations for the excellent lectures. For the beginners, I'm sure that it's the big step for start to perform this kind of procedures. If I could ask you for the first lecture, what kind of needle do you rather prefer, the cytology or histology with FNB? Because now we have these different kinds of needles, which are thin needles as 22, 25, but with the possibility of taking a piece of histology, yes, as Procor or acquire needle. What's your decision for lymph nodes? Rather FNB or FNA when it comes to the mediastinal lymph nodes?
For staging of non-small cell lung cancer, I generally prefer standard aspiration needles because they have enough diagnostic capacity. But if I am dealing with a suspicious lymph node, if the issue is lymphoma, then you need tissue diagnosis because pathologists want to work with immunohistochemical studies. So you need the tissue itself. So in this sense, I generally prefer acquired or procore type FNB needles. So if I need more tissue, I prefer FNB. Otherwise, for malignancy staging, I prefer FNA needles. That's the main idea, my approach.
Thank you very much. Thank you.
Professor, I have a question for you. You have very nicely demonstrated demonstration of area 4L and 5. I do believe that if we make an effort, we can look at area 6 through EUS. What are the special ways with which we can look through area 6 to EUS, and can we obtain an FNA in this situation as it changes the staging from N3 and N2? And you know that these are important for us to pick up which lymph nodes to be taken.
Okay. First of all, I have to explain that in many workshops or also in some books, it is generally regarded as station 5. Indeed, what they are generally looking is station 4L. I have to underline it because generally there is confusion. Indeed, we mostly look to station 4L. Station 5 is away from the ligamentum, and station 6, it is the para-aortic region. It's always difficult to reach that area. There are reports in some cases to traverse the aorta and take biopsies. You can find reports, but it's not my usual practice as it is aorta, but it is possible, I know, and there are reports. And how it changed the staging, I'm not sure indeed at this stage, because we always discuss these findings in a multidisciplinary discussion meeting. So I can not make strict conclusions about the station 6 at this point. I'm sorry.
Thank you. I have my next question for Professor Eisendrath. Professor Eisendrath, at the beginning, when we start doing an endoscopic ultrasound, when we try to position our scope in the second part of the duodenum, it tends to flop over as we come out. What are the special tricks so that you have a stable position in the third and second part of the duodenum?
Good question. Thank you. Yes, indeed, and as I addressed it already during my speech, I think the secure position is to turn clockwise. So by this way, by turning clockwise and having a hub position with the great wheel, you are in a secure position. And you have to expose yourself and you risk to be expulsed into the gastric lumen by turning counterclockwise. But this is always also the way you will be able to explore the papilla and generally what you want to see. It's surrounding the papilla and the common bile duct for those who are looking for, or the end of the common bile duct for those who are looking for stones. And so it's really a step-by-step procedure. When you start from the mesenteric vessel and you are retracting your scope slowly, step by step, 2 centimeters by 2 centimeters, and turning clockwise to be secure, retract, and then expose by counterclockwise to see if you see the papilla. And if you don't see it, you go back clockwise, you retract a bit more, and you expose again in the counterclockwise. And this is the way I'm doing the procedure, and I avoid to be expulsed.
Thank you for that.
Yes. Can I ask questions to Pierre Eisendrath? Thank you for your very interesting presentation. And as you know, during the EUS procedures, it's possible to differentiate some anomalies. For example, pancreatic division. You showed your lecture. What is your opinion this about pancreas division and the other anomalies, junctional anomalies?
Yeah, so indeed, depending of the EUS-friendly patient, you are able sometimes to really delineate the ductal anatomy, and it's sometimes obvious that the central duct it's the main pancreatic duct, and there are no connection with the ventral duct, which is the definition of pancreatic divisum. However, you know that now, if in the history there was really a differentiation between pancreas divisum and normal anatomy. Firstly, pancreas divisum is not clearly associated with pathology, so I would say just a variability of the anatomy. And also the other point is that sometimes, because we have this capability of having a better view on some ductal structure compared to other type of imagery, you are able to see small ductal connection, which is the definition of incomplete pancreatic divisum. So you have something that we call the dorsal dominant structure, which obviously you see that the main duct is going to the minor papilla, but you are sometimes able to see that there are some connection, which is the definition to me for the incomplete pancreas divisum. I don't know if I answered your question.
So maybe, Pierre, we could summarize telling that for pancreas divisum, the sensitivity of EUS is not so good, but the positive predictive value is good.
Yes.
Do you agree?
Perfectly, perfectly.
Thank you very much.
And Professor Pierre, one question when it comes to the technical examination of pancreas. Is the balloon necessary for performing excellent examination of EUS of pancreas, in your opinion?
I wouldn't say that it's necessary. To my point of view, it's sometimes helpful, but in most of the time, I'm not inflated to the balloon. So for having the image, to my point of view, the utility of the balloon, it's probably less than 5%. In 5% of the cases that I will need the balloon to have a better view of the parenchyma. However, if I'm starting with a fellow, I'm happy to have the balloon in place because I like to have the balloon slightly inflated just to reduce the aggressivity of the tip of my scope, particularly when they have to insert the scope into the pharynx, and also when they have to pass the genus superius. From the bulbs to the condylodenum. So it's more a security than a need for having a nice exposure of the parenchyma. This is my feeling. But I'm totally able to have I
want to say that really it's a very important question because, as you know, the balloon inflation by the small channel for filling the balloon is a source of infection and contamination. And it's very difficult to clean this small channel for filling the balloon. And we have a lot of infection related to this small channel. So I asked to the company, okay, the balloon is not so helpful for linear examination, so you can cancel this channel because it's a source of infection and contamination. So maybe we have to discuss between us if the filling the balloon is so helpful for linear probe, because adding the operating channel, the elevator, and the balloon filling, it's highly risky for infection. No?
Is the question to me?
Yeah, it's a question for everyone. I think experts.
I would say that it's a very interesting comment, Mark. I didn't realize that before, and your comment is certainly interesting. And again, I share your point on the fact that the balloon is not needed to have a good examination in most of the cases. So I perfectly agree with you concerning the fact that it could be removed, but I have the feeling that I would like to have your opinion about that. Some kind of security. You are starting with one fellow, but maybe you don't share this opinion.
Maybe you can ask to Ken. What is your opinion?
Indeed, somewhat same with the Professor Eisenfeld. For the mediastinal imaging, I rarely use balloon, but it is useful for patients with heterogeneous esophagus. They are generally old patients to rely on the mucosa to be in good contact to give us a very good acoustic window. So I use it. And also for difficult cases at the GE junction, I always inflate it sometimes for proper positioning. In other situations, a slight installation generally gives a very good acoustic contact with the mucosa. But I know the issue, what you have mentioned, many centers use balloon to prevent infection because of the infectious risks. So I always put balloon on the scope, is for sure, but how many times you use? Maybe 10%, maybe 5%.
So in fact, you use, most of the time, you use a balloon to protect the channel, to avoid infection of this small channel.
Yeah, this is totally right. And also, not for the mediastinal, but while I was taking biopsies from the junction of head and the body, I need sometimes to fill the balloon and come back from the bulbous towards the stoma. At this time, it also gives me stabilization, the other issue. And the third issue is while examining the subepithelial lesions. But I know in many centers uses balloon just for prevent infection.
Okay. So have the moderator some question more?
Thank you very much. When it comes to the pancreas, definitely more important is this balloon in the second part of duodenum and tumor stabilization of the echoendoscope. But when it comes to the rest of part,
What?
Anna disappeared. Okay. You understood the question of Anna?
I believe it was more a comment about the fact that the balloon was useful to stabilize the scope into the second duodenum compared to the stomach.
And Pierre, I have a question for you. Maybe you cannot answer, but it's the question is about the different scope coming from different companies. So have you different way to get pancreatic images with using a Fujiscope, using a Pentascope, or using Olympuscope?
Ooh, this is a difficult question.
Yes.
Because it's also, I would say that the variation to get image is more related to the position of the patient, backwards or on left side position, and the anatomy of the patient, that to the scope. But I have the feeling that because in fact I'm mainly using one kind of scope, and I've maybe less than you the opportunity to compare the different kind of scope. But I have the feeling that with the Olympuscope, you get the image particularly, and just one comment before, I think this is particularly true when you are speaking about the bulbous station. It's less true when you are speaking of the gastric station. But concerning the bulbous station, I have the feeling that with the Olympuscope, you need less to be pushed into the bulb. You don't have to be as forward in the bulbous structure compared to the other scope and the Fuji, for example. This is my feeling, but I return the question to you. What's your feeling about that?
My feeling is it's not important for the stomach examination, through the stomach examination, but for transduodenal examination, it's very different from a different company, because I think it's a problem of the length of the acoustic probe, and also from the distance between the acoustic probe, the US probe, and the tip of the endoscope. Especially, I saw a lot of difference between the Fugiscope and the Pentaxcope when you are going out of the third duodenum, coming into the second duodenum to see the major papilla. I saw that with Fugiscope, you are less stable than with the therapeutic EUS scope from Pentax. So you have to change a little bit, using more rotation to be more stable. So it's only a question of use, but you have to know that. And when I'm doing I'm working with attendees in my unit. We have the three different scopes: Olympus and Fuji and Olympus, and we saw that the acquisition of the images are different, and the stability through the second and third duodenum is not the same. But it's only a question of use, but you have to say that to the student. Take care, because with some scope like Fuji and also a little bit Olympus, when you are going out of the third duodenum in direction of the second duodenum and to the major papilla, you are a little bit less stable. What is your opinion of the different moderator?
Well, I think Fuji scope has you see the tip of the scope better if you're using Fuji echo endoscope. Gives me assurance. I mean, I feel more comfortable because the view is large. And you talked about the images in the second part of the duodenum. You can more easily see papilla and the structures with the Fuji scope when compared to, for example, because its view is better, and you see the tip better. And it is especially useful during biopsies, indeed. And also the other point is, I think the image quality. Also, it depends on the ultrasound machine, and also it depends on the monitor, if you are using a 4-key monitor or something else. And there are some differences. For example, Olympus images are more softer. The outlines are more softer. If you are using Fuji system, the newest system, borders are more clear. As you can see from the presentations, I generally give Fuji videos and pictures. The outlines are very clear. But at the end, I generally use for the Olympus images, they are more softer. So it, of course, depends on the endosonographer, but I generally prefer clear images, clear lines or borders. And also, I would like to see the tip of the scope, and I always want to control where the tip is while using, especially for difficult biopsies. That's my preference.
And for both of you, we have a question about the respective use of radial probe or linear probe. What is your experience? Do you prefer to use both? Do you prefer to use linear probe? Do you prefer radial probe? Or is it depending on the indication?
Well, I generally prefer linear probe. Very, very rarely use radial probe. For especially mediastinal imaging, linear probes gives you very good borders for stations. And with radial images, imaging, it's more difficult to find the stations. If there is obvious lymph nodes, of course you can see. But for linear imaging, the station borders are better defined, I guess. And you exactly see what you would like to see. The region is very clear. And it also gives opportunity for sampling. And I only use radial scanning in very few cases, like subepithelial lesions or something like this. But I 99%, let's say 95% linear scope. In my practice, I use linear scope. And I think I forget to use radial scope.
And Pierre, what is your advice?
Almost the same answer. So I mainly use linear scope for all indication. I told you already in my talk that I'm only using linear scope for pancreatic indication. And on the reverse, I can say that I use radial scope as my colleague for evaluating subepithelial lesion most of the time, not always, and also for rectal tumor evaluation. So these are the two indications when I keep my radial scope. But if I have to start a new clinic and I have to buy a scope, it will be a linear scope for sure.
Okay, for sure you will buy a linear probe. Okay. So other question from the moderators?
Yes, Professor Isidrat, which position you prefer to have a better imaging, prone or left lateral?
That's a nice question also, thank you. In fact, I changed my mind. I was usually working in well, I'm still working in an academic hospital where most of the patients are intubated, and this is also an answer to a question which was asked in the mailing. So in that center, my patients are on general anesthesia with a tube, and so they are on the back position. And just because we were lazy, I was doing my linear examination on the back. But since then, I moved to another hospital where I'm also working, and there the patients are just on propofol, so they are on the left side position. And I feel more comfortable to do my examination on left lateral position compared to the back position. So I feel that I have a better view, particularly on the bulbar station. But for the duodenal station, and this is going back to the previous question, I feel that we are a little bit less stable, and we are much more keen to be expulsed in the gastric situation. But again, it's just a question of training. So my preference for the left lateral position with a patient on propofol.
Okay, so coming from the chat, we have two more questions. One is about the infection of the EUS cup. Have you a lot of infection with the EUS cup? And they didn't understand what I was speaking about the infection of the accessory channel for filling the balloon. I just spoke about that because you cannot brush this channel. And this is really a problem to clean it clearly. So this is why I spoke about this problem. And the second problem after infection and disinfection of the EUS cup is a problem of sedation. What kind of sedation do you use? Midazolam or propofol?
So
I think
please go ahead. Go ahead.
In my practice, I mostly perform my EUS procedures under propofol sedation, and they generally give balanced anesthesia, which includes small doses of midazolam plus propofol. And I'm working with the anesthesiologist. So they are under moderate sedation. But we have to underline some fact. If we are planning to do a cyst drainage, then patient had to be intubated because fluid rapidly comes into the stomach and the aspiration risk increases. So we have to underline this issue. You know, other situations you can do it, of course, under propofol sedation, but for this particular cases, intubation is absolutely needed. But I know, because I've worked also in Brussels, Belgium, they also would like to do it under general anesthesia with intubation. Yeah.
So Pierre, what do you think?
It's almost same answer. Most of my procedure, which are diagnostic or with tissue acquisition, is on propofol, left lateral position. But for therapeutic procedure, I prefer to have my patient general anesthesia with intubation, and then are or on the back or they are turned on the left side. But when there are therapeutic procedure with X-ray utilization, I prefer to keep my patient on the back. It's better view for the X-ray.
Yeah, exactly. And I think that if you need to have any intubation for your patient, sometimes for anesthesiological reason, you have not to let the patient on the back on supine position if it is only for diagnosis. But of course, if it is for treatment, on the back, because you have X-ray, and so you have a better delineation of the anatomy. But if you need to do only acquisition of the diagnosis, on the left position, I don't know why, you are better placed for doing EUS examination only for diagnosis. I don't know why, but it's my experience. I don't know if it is yours for moderators and experts.
Yes, indeed, I shared that with you previously. I prefer to have a left lateral position for pancreatic examination. And I believe, but I'm not sure, that it's because particularly on the bulb position, for the bulb station, sorry, the hilum block, the liver hilum block is more proximal, it's more close to the probe and more exposed. I suppose it is this, but again, as you, I'm not sure of it, but I feeling better position it, and the ability to obtain the good image, it's easiest in this situation.
I also prefer left lateral position, but I'm not sure if I'm used to do it. That's why is it the reason. But of course, in intubated patients, I work on the spine position, but I generally do not feel so much difference, but always going, I totally agree, going into bulk is more easy, I think, in the left lateral position. That's for sure.
Okay, so I think we are ending this first session. I want to thank the moderator, Anna, Dilek, and Rajkumar, and also, of course, our experts who were speaking, Ken and Pierre. So thank you very much to share with us your experience, and it was really great lectures coming from both. Okay, so thank you very much. We are going to start the second session. Thank you.
Thank you.
Thank you, Rajkumar. Okay. So now we are going to start the second session. So I don't know if we have Chris Core.
Yes, I'm here, Mark. Hi, how are you? Okay, I think you're muted now. I guess I will start the second session on tumor staging. My name is Dr. Christopher Kaur, and I'm from Singapore General Hospital. And I wonder if my two co-chairs are here, because I'd like to ask each of them to introduce themselves in turn. Dr. Emrah Alper, are you here? And also Dr. Abdul Hadi Quadri, is he here as well? Let me see. I guess we will have to.
I'm Dr. Alper, I am here.
Hi, Dr. Alper. Could you introduce yourself to our audience, please?
I am Dr. Emrah Alper from Istanbul Koç University Hospital.
Okay, well, welcome, Dr. Alper.
Thank you.
And Dr. Quadri, are you here? Okay. Well, I guess if you're not logged on yet, it's okay. We can introduce you a little bit later. But so this is session 2 on tumor staging. We have 3 talks ahead of us. The first is on EUS and pancreatic staging, and then biliary staging, and then the third talk will be on hands-on training in FNA and FNB. So without further ado, let me just introduce the first speaker for this session. This is Dr. Yusuke Nakai, who is Associate Professor of Medicine at the Graduate School of Medicine in the University of Tokyo. Dr. Nakai, I'm proud to say that he's a good friend and he's an excellent researcher. He's one of the pillars of our Asia Pacific Pancreatic Biliary group. And he's responsible for anchoring his team, which has led a huge number of high impact publications, the latest of which was their EP-LBD study without sphincterotomy versus sphincterotomy in patients with large biliary stones. But today he's going to be talking to us about a slightly provocative topic, on EUS staging of pancreatic cancer. Is EUS still needed? Dr. Nakai, are you there?
Yeah.
Can we ask you to start your presentation, Yosuke?
Okay, let me start.
I'll get you to share your screen. I'm actually still seeing Dr. Bartez. Okay, all right, Yosuke, you're on.
Can you see it?
Yes, terrific. Please go ahead.
Okay, I will start my presentation. And please for kind introduction. So my topic is EUS staging of pancreatic cancer, and is EUS still needed? So because this is a EUS conference, of course the answer is yes. This is my slide. So as we all know, the incidence of pancreatic cancer is increasing. Now it's also leading cause of death in Japan. There are some roles of EUS in pancreatic cancer. First, detection, and then staging and tissue acquisition. And this is still experimental. There might be a role in the FNI injection or ablation in the near future. So first, I will talk about detection of pancreatic mass. This is a review by the Professor Kitano. So sensitivity of EUS to detect the pancreatic mass is 94%. It's better than CT or ultrasound or MRI. But when you look at the published year, this is most of the paper more than 10 years ago. So there may be some difference in the recent CT scan because it is getting better day by day. And this is a study comparing CT and EUS, but this is only negative CT. In 206 cases with clinical suspicion of pancreatic cancer, but with indeterminate CT scan, EUS detect the mass in 70%, and 40% were pancreatic cancer. So, and the size of the region is about 2 cm. So there may be some superiority of EUS in small pancreatic region. So this is a staging. Again, most of the study is more than 10 years ago. Sensitivity of EUS for regional lymph node is 69%. And the vascular invasion is 85%, and the detectability is 90%. And if you compare with the CT scan, lymph node staging, vascular invasion, and the detectability, all of these parameters are better than CT scan. I will talk about vascular invasion. This paper was published in 2001, almost 20 years ago. In this study, EUS shows a better sensitivity of vascular invasion compared to CT scan. However, when you look at these CT images, these are different from nowadays very good CT scan pancreas protocol. So now I think CT can detect better vascular invasion, but I will talk about this later. So if you, our goal is better survival of the pancreatic cancer patient, and if you perform EUS, does it improve survival? In this study, then compare patient with pancreatic cancer with EUS or without EUS at the time of diagnosis. And this study shows better survival in the EUS group. So I think with the EUS, we can get a better staging and we can choose appropriate treatment. So that's why EUS can improve the survival. However, recently we perform EUS guided tissue acquisition more and more, even in patients who will have a surgical resection. And we all know sensitivity and specificity of EUS guided tissue acquisition is very good. Like this kind of lesion, some soft tissue around the vascular vessel artery or vessel veins, we can perform EUS FNA. This is a study from Korea. They perform these kind of vascular curve, and the diagnostic rate is 65%. It is lower than the pancreatic mass, but still it can help the diagnosis of vascular invasion. Like this case, you can see some tissue around the celiac artery. On EUS, this is the aorta and the celiac artery takeoff. There is some tissue around the artery. Even in those kinds of lesions, we can perform EUS FNA carefully. So we can puncture this kind of vascular curve using a FNA needle, and we can get a diagnosis of pancreatic cancer. How about the lymph node? This is a study from Japan. They try to compare EUS FNA and the PET CT scan for non-regional distant lymph node metastasis. And they showed EUS FNA was better than PET CT because those lymph nodes are not so big, so PET CT scan is not so sensitive. And they perform EUS FNA in those regions, and they can avoid unnecessary laparotomy in some patients. And we can also check liver, especially in the left liver. EUS can detect liver lesion even if CT was negative. In the left, it's reported in 2004, they found a liver lesion in 8.5%. And in the right, this is a recent paper. They performed a contrast-enhanced EUS, and they detected left lobe liver mets in 2.1% in the Cooper phase of the contrast-enhanced EUS. And we can also detect peritoneal carcinomatosis by EUS. In case with ascites, EUS detected carcinomatosis in 30%, and in patient without ascites, it's 4%. It's not so often, but we can avoid a laparotomy in those patients with positive EUS findings. And I will talk about the neoadjuvant treatment in the pancreatic cancer because this is a big change for us. This is because even if the CT scan showed a resectable pancreatic cancer, at the laparotomy we find a small metastatic lesion or severe vascular invasion. It is reported about 25%. And after curative resection, we have to give chemotherapy as adjuvant treatment. But after invasive pancreatic resection, some patients cannot tolerate the adjuvant chemotherapy. So we are going forward to neoadjuvant chemotherapy recently. This is NCCN guidelines for the workup of pancreatic cancer. So, of course, we perform CT scan first to check metastasis. And if it's positive, we can perform EUS FNA like this. And if it's negative, we can repeat CT scan for the chest or pelvis. to find a small distant metastasis. And we can also perform EUS for local involvement or liver mets or carcinomatosis. And the MRI is also useful to detect the liver mets. This is a bit different from the past. In the past, we thought vascular invasion is yes or no. But recently, we have a new concept of borderline resectable pancreatic cancer. So now it's resectable, borderline resectable, and unresectable. To categorize these cancers, we have to detect cancer involvement to the vessels more than 180 degrees or less than 180 degrees. So it was not yes or no. So in this point, I think CT scan is more objective. EUS is kind of subjective diagnostic modality. So it's difficult to tell it's more than 180 degrees on EUS or not. So in borderline resectable pancreatic cancer, we are gonna do FNA and then give a neoadjuvant chemotherapy. And the resectable pancreatic cancer, there are two options now. We can have a surgery first approach, or we can give a neoadjuvant therapy even in patients with resectable pancreatic cancer, because in some patients, there is some small distant metastasis or local invasion. This is international consensus for borderline resectable pancreatic cancer. They defined ABC classification. On CT scan, it might be resectable, but if the patient has a regional lymph node or elevated CA19-9 levels, in those patients, upfront surgery approach is not so good because the patient may have a early recurrence. So they recommend to think those patients as a borderline and give a neoadjuvant chemotherapy first, rather than upfront surgery. And this is a time trend of EUS for preoperative pancreatic cancer patients. As you can see, the blue bar is EUS FNA, and the green bar is EUS, but without FNA. We have more and more patients who undergoes a EUS FNA, as you can see. But the problem is that there is some kind of concern for the tumor seeding. However, in this study, EUS FNA did not impair cancer-specific survival. And this is a recent Japanese multi-center study. They again compared EUS FNA and without EUS FNA group. And they again also find that there's no effects of EUS FNA for the survival. However, they found a needle tract seeding in 3.4%. All the patient has a pancreatic cancer in body and tail, and the needle goes through the gastric wall. And after 6 months to almost 3 years, they found that these kind of submucosal lesion in the gastric wall at the needle tract. And that's 5 out of 6 patients had a surgical resection for needle tract seeding, but in one patient, the patient had a chemotherapy. When you look at the surgical staging, the number 5 and number 6 patient has a T1 M0 M0 lesion. So it should be curable, but the patient has a, unfortunately, a needle tract seeding. So we should be aware of this kind of risks. I will talk about early pancreatic cancer. This is a recent Japanese multi-center study collecting 200 early pancreatic cancer, meaning stage 0 or stage 1 pancreatic cancer. When you look at the survival curves, we should diagnose pancreatic cancer at the sub-centimeter of the size to cure the pancreatic cancer. In those patients with a very small pancreatic lesion, EUS detected mass in 76%, and the CT detected 50% in stage 0 and the stage 1 patient. However, in the stage 0 patients, EUS only detected 24% mass and the CT detected 10%. Because this is a stage 0 cancer, the cancer itself does not form a mass lesion. It's inflammation or fibrosis around the cancer. So I think it's difficult to detect these kind of small cancer on EUS or CT scan. We found more ductal changes in those lesions, even in CT scan or MRI or EUS. How about the diagnosis, tissue diagnosis of these kind of early pancreatic cancer? We prefer ERCP with a nasal tube to perform pancreatic juice cytology. In the diagnostic rate, EUS FNA and the ERCP with the nasal pancreatic drainage tube is same in stage 1. However, in stage 0 patients, ERCP is better than EUS FNA. So in Japan, we prefer ERCP in those kind of very small lesions. Finally, I will talk about molecular analysis of pancreatic cancer. It was just a cancer or non-cancer before, but we are having a molecular analysis recently. And there's some kind of subtypes defined by those kind of molecular analysis. So under this kind of subclassification have a different overall survival. When you look at the NCCN guideline and the metastatic diseases, they recommend gene profiling recently for the metastatic pancreatic cancer. And for EUS FNA, we have new kind of FNB needle. So we are changing from A to B. We have a couple of needle for FNB. And this recent study compared EUS FNA and the EUS FNB for OncoPanel. When you look at just the diagnosis of pancreatic cancer, EUS FNA and the EUS FNB is same. However, when you look at the adequacy for OncoPanel, FNB needle is better than FNA needle. So recently we are using a FNB needle more and more. This is my final slide. For diagnostic yield of pancreatic cancer, I think EUS still has better, but the CT is also improving. However, in the era of neoadjuvant treatment, the role of EUS for local involvement is decreasing. But EUS can diagnose distant non-regional lymph node or occult liver metastasis or peritoneal dissemination, better than CT scan or PET-CT scan. And the EUS guided tissue acquisition plays an important role more than ever because we are giving a neoadjuvant chemotherapy, and even in undetectable cancer patients, we have to perform genome profiling to get individualized treatment. Thank you for your kind attention.
Thank you very much, Yusuke. I think you're muted, Mark. Yeah, Mark, we can't hear you because you're muted.
Okay, now you hear me?
Yes, we do now.
Congratulate Yosuke because it was so nice presentation, very complete. So maybe the moderator have some questions? Waiting for the chat.
Yeah, I think we're going to keep the questions till the end, perhaps, are we? For the discussion time? Or
yeah. So we keep the question for the discussion time. Okay. So Emma, you want to introduce the next speaker?
Yes. Good afternoon. The next speaker will be Dr. Linda Lee from the Harvard Medical School, Berkham and Women Hospital Medical Director of Endoscopy. Her lecture will be the bile duct tumors of staging with EUS. Dr. Lee, please, you can begin.
Great. Well, thank you so much for this invitation. I really appreciate it. And it's been a wonderful conference so far. Hopefully, one day soon we can actually see each other in person. So for about the next 20 minutes, I'll be talking about, as you heard, EUS in bile duct cancers. So there we go. So I'm going to start off by talking a little bit about background. Because this will help us to understand where the role of EUS is in cholangiocarcinoma. As you can see here, it's a minority of cholangiocarcinomas that present in the intrahepatic ducts. About half of them present in the perihilar region, which of course gives us headaches when we're trying to do ERCP on some of these patients. And then about a third, maybe a little bit over a third of cholangio-CA is present in the distal extrahepatic bile duct. And it's really the perihilar distal extrahepatic patients where EUS can be particularly helpful, potentially in diagnosing as well as in staging. I do want to spend a minute talking about the different morphologic subtypes of cholangiocarcinoma because, again, this helps us to understand where EUS can be helpful, especially in diagnosis. So for distal and perihilar cholangio-CAs, which is what we're mainly seeing with EUS, overwhelmingly the most common morphologic subtype is this so-called periductal sclerosing. And as you can see here from this cartoon, this means that the cancer is infiltrating in the wall of the bile duct. So I think you can pretty easily understand why simply doing brushing of the bile duct during ERCP or even just biopsying the mucosa may not give us a diagnostic yield. And this is where perhaps FNA can be helpful, where you're biopsying and sampling the wall. The other two subtypes that you see there include the nodular or annular in the middle, and then the polypoid or papillary type, which is where there's an actual mass that's protruding into the lumen of the bile duct. So you can imagine in those subtypes, you probably will get better diagnostic yield by just doing brushing or biopsying. But again, this is much less common than the periductal or sclerosing subtype. And, unfortunately, cholangiocarcinoma, the survival still remains not very good. As you can see, these are tables taken from up to date. And you can see here that for the T staging on the left side, T1 has kind of modest survival at 5 years, about 70%. However, once you're at T2 or T3, very poor survival rate. And on the right, you see the survival based on nodal staging, and any lymph nodes certainly decreases your survival. I will talk a little bit about the modifications to the TNM staging that happened a few years ago, but for distal cholangiocarcinomas, it basically relies on the depth of involvement or invasion of the bile duct wall. So the deeper the involvement, the worse the survival. And again, this is where EUS can be helpful, because if we can do more accurate staging, we can prognosticate better. So these are the TNM, the revised TNM criteria. This is for distal cholangiocarcinoma. And again, the main thing to note is that for T staging, you have to measure how much the tumor is involving as far as the wall of the bile duct. And for nodal staging, it depends on the number of lymph nodes. For perihilar cholangiocarcinoma, the T staging is different. It depends on whether or not there's invasion into surrounding structures. And again, nodal staging depends on the number of lymph nodes. So, the treatment, if you're intending to cure a patient with cholangiocarcinoma, the only cure that we have is curative surgical resection or potentially liver transplant. And the criteria for surgery include the absence of regional lymph node metastases, as well as invasion, vascular invasion and various organ invasion. So again, the role of EUS in cholangiocarcinoma, both diagnosis as well as staging. I'm going to spend a quick slide just reviewing when we encounter biliary strictures, what are we doing? Often we may end up starting with an ERCP. Sure, we can aspirate bile. Sensitivity is not that great. We can do brushing. We all know the challenges with that. We can certainly stick biopsy forceps up there, maybe a little better, but still, not perfect. You combine the two, a little higher sensitivity, and then these adjunctive techniques that we can use, including FISH, fluorescence in situ hybridization with the labeled probes to look for chromosomal aneuploidy or polysomy, as well as genetic mutation detection that may be helpful. However, we still encounter this problem of indeterminate biliary strictures, and the problem goes both ways because up to 2/3 of these strictures can be malignant, and of course we're always worried about missing malignancy in these strictures. But on the other hand, up to 20% of patients that we send for surgery because we're worried about malignancy end up having a benign stricture. And of course, these are, fairly morbid procedures that we'd like to avoid if we can. And, this is again where we have EUS FNA, intraductal ultrasound, of course, cholangioscopy. And this is just a video showing a polypoid lesion there on cholangioscopy that you can biopsy, as well as PCLE, confocal laser endomicroscopy, and OCT. I'll obviously be focusing on the ultrasound techniques here. So for EUS imaging alone, this is the sensitivity and specificity when it comes to diagnosing these lesions. And we're looking, of course, for the presence of a mass. And this particular image shows you a small mass involving the bile duct and kind of extending out from it. You see how the borders are irregular here. Other imaging findings we can look for as hints of malignant stricture is if the bile duct wall is irregular or if it's more than 3 millimeters thick. Of course, if you add FNA to simply imaging, the sensitivity and specificity does go up. In terms of doing EUS FNA, talking about the perihilar lesions, the one thing just to remember is that you do not want to FNA perihilar lesions if you think your patient might be a liver transplant candidate. And this is really more based on literature looking at biopsies that were performed transperitoneally and found really high rates of metastatic disease happening in those patients compared to patients who did not have a biopsy via that route, but we extrapolate to EUS FNA in this area. So that's something important to remember. For distal lesions, there is some literature that suggests the diagnostic yield is higher with EUS FNA of distal lesions compared to more proximal lesions, although other literature suggests the sensitivities are comparable. And it's certainly safe to perform EUS and FNA of lesions in the bile duct without a stent if you're not puncturing the bile duct lumen. And so if you look at this EUS image in the upper left here with all the red arrows pointing at the mass, if your needle is just going straight directly into this mass, as you see on the right upper panel, that's completely fine. The patient does, you do not need to have a stent in this patient. However, if your needle, for whatever reason, ended up going through the lumen of the bile duct here, you see the bile-filled lumen, the anechoic space to the right of the mass. If your needle is piercing through that in order to get to the mass, then that's when you should be placing a stent in case the patient develops a bile leak. Ideally, of course, it'd be best to do EUS and FNA of these lesions before any stent goes in. That's not always the case, but if possible, that would be ideal. And of course, the problem with stents, in particular metal stents, as you see in this lower left photo, is that it causes all this acoustic shadowing. So it's impossible to see what's going on in this area. It is certainly much less of a problem if you simply have a plastic stent in place, as you see in this lower right EUS image, where you see the drain there. So with the plastic stent, you don't get nearly as much acoustic shadowing, and it's easier to image. There's a study that looked at 150 patients and found that performing EUS FNA was not associated with increased recurrence or decreased survival in these patients. And it certainly is useful to do after an initial negative ERCP with brush cytology. I'm just going to say a quick word. This is a feasibility study that was done last year, looking at the feasibility of using EUS FNA acquired tissue to perform personalized targeted molecular therapy. In this study, they performed rapid on-site evaluation and then immediately refrigerated the samples at 4 degrees Celsius and was able to perform extraction of material needed for molecular therapy. So hopefully we'll be able to do more of this for our cholangioCA patients in the hopes of improving their survival. Now, I wanted to spend a little bit of time on intraductal ultrasound. We don't do a lot of this in the US at least, but it can be very useful for differentiating benign and malignant strictures as well as doing T-staging. And, you know, in terms of what a normal bile duct wall looks like on intraductal ultrasound, it can look like having 2 or 3 wall layers, and usually the bile duct wall is less than 1 millimeter in thickness, although if there's a stent in place or a percutaneous drain in place, it can be up to 3 millimeters thick. And I just want to draw your attention to this EUS image at the 2 to 3 o'clock area. Here you see, if you look at 2 to 3 o'clock, you see normal layering of the bile duct wall. So this is 3 layers that you see here. The inner hyperechoic bright layer is the interface between the bile-filled lumen and the bile duct wall. And then the hypoechoic layer just deep to that represents the mucosa, muscularis propria, and the fibrous layer of the subserosa. And then deep to that layer, you see this bright hyperechoic layer that is the outer layer representing the adipose layer of the subserosa, the serosa, as well as the interface between the serosa and the surrounding tissue there. Now, when you look at 9 to 12 o'clock, you'll see that there's a complete loss of these wall layers, and you see this hypoechoic mass here, you know, a somewhat irregular border, and you know, certainly does not look like the normal layering of the bile duct wall at 2 to 3 o'clock. So you can relatively easily identify that there's a small mass here in the wall of the bile duct. And so, you know, these are some of the criteria that we're using when we're trying to identify malignancy with intraductal ultrasound. As I already mentioned, the disruption of the normal architecture, the layering of the bile duct wall, eccentric wall thickening, as you can appreciate in this upper photo, the same photo I showed earlier, where obviously there's some thickness going on here that's not present in the normal area, hypoechoic mass. And then the lower image is pretty obvious, where you see a circumferential hypoechoic mass with these irregular margins here. And you might be able to see sometimes some lymph nodes. although again, since the intraductal ultrasound probe is high frequency, there is decreased depth of penetration, so you'll only be able to see lymph nodes that are very close by to the bile duct wall. In terms of diagnosis, this is the overall sensitivity and specificity using intraductal ultrasound. And studies have shown that if you add intraductal ultrasound to ERCP with cytology, there's improved sensitivity in diagnosing these malignant strictures from the kind of 50–60% range all the way up into the 90s. And when you compare EUS to intraductal ultrasound, again, intraductal ultrasound appears to have higher sensitivity and accuracy. Just to point out the small little lymph node next to the bile duct wall, as well as this hypoechoic mass that you can see at the 6 to 9 o'clock range. Of course, the downside is that you can't get any tissue with intraductal ultrasound, but certainly if you can see something like this, it is very concerning for malignancy and not a benign process. So in terms of the approach to diagnosing distal biliary strictures, if the patient does not need to have an ERCP for biliary drainage at that time, really you should do EUS FNA. If your needle happened to pierce into the lumen of the bile duct wall, then you should be placing a stent after that. And of course, if your EUS FNA was non-diagnostic, then there are all these other techniques that I mentioned earlier that you can then pursue. In terms of the approach to diagnosing perihilar biliary strictures, we again have EUS FNA with the caveat that perhaps there may be lower diagnostic yield in these proximal strictures. And just remember that if your patient might be a liver transplant candidate, do not biopsy or sample the perihilar lesion. Now, a word about the approach to diagnosing these indeterminate biliary strictures, which can be the bane of our existence a lot of times. We all know about cholangioscopy. The downsides, of course, is that it's expensive, and cholangitis can happen in up to 10% of patients. However, you can certainly get these beautiful images, as you can see in the middle panel, with the irregularity in the mucosa and the vascular pattern there. This study looked at patients who had no mass seen on CT or MRI, already had a negative ERCP with negative cytology and a plastic stent placed for the biliary stricture. And in these patients, the next step they did was they did EUS FNA with 4 passes. If the EUS FNA was negative, only then did they bring the patients back for cholangioscopy with at least 6 biopsies and suctioning the biliary fluid for cytology. And what they found was that by doing EUS FNA first, or trying to do EUS FNA first, they saved 60% of patients from needing to have cholangioscopy. And EUS FNA was possible in 63% of these patients with a 92% diagnostic yield. Cholangioscopy was possible almost all the time with about an 88% diagnostic yield. So certainly, if you don't have access to cholangioscopy or concerned about the cost, it does seem reasonable to do EUS FNA first. Now, just to finish up by talking about staging, for T staging in cholangiocarcinoma, intraductal ultrasound seems to be more accurate than EUS. It is very good at detecting early lesions. As I showed you, the small masses, also good at detecting or determining the longitudinal extent of the malignancy in the bile duct, as well as extension into adjacent organs. However, intraductal ultrasound is not as good for nodal staging, again, because of the poor depth of penetration. And so this is where EUS is very helpful. EUS has been shown to be superior to radiology imaging in identifying regional lymph nodes. The one thing to remember, though, is that EUS image for the typical malignant lymph node that you heard about in an earlier talk does not correlate with the cytology results. So that's why if you see these lymph nodes, you should FNA any lymph nodes that you're seeing. So, pretty much, since we know that nodal staging is related to survival, as well as whether or not these patients can undergo surgery. If somebody does not have evidence of metastatic disease, then patients really should be undergoing EUS to perform the best nodal staging possible. And you can see here with this yellow arrow pointing to an over 1 centimeter hypoechoic, well-defined lymph node there that you should still be sampling. One interesting paper is where these lymph nodes are. And so I just wanted to point out that in extrahepatic cholangiocarcinoma, in this paper from last year, as you might expect, almost half of these lymph nodes are in the periportal area. However, what's interesting to note and important to remember, I think, is that the other lymph nodes were fairly evenly distributed all the way from the periesophageal mediastinal area, celiac, gastrohepatic, as well as the aortocaval region. So we really should be looking at all these areas in somebody that has extrahepatic cholangiocarcinoma. On the other hand, patients with intrahepatic cholangiocarcinoma, as you also might expect, nearly 2/3 of them had periportal lymph nodes. But to note here that none of these patients had periesophageal, mediastinal, or aortocaval lymph nodes. So one final slide before I conclude, just to remind us about EUS versus intraductal ultrasound. Intraductal ultrasound seems to be superior in determining the cause of the biliary stricture, as well as predicting resectability and T-staging. Not as good for obvious reasons for nodal staging. And so the majority of cholangiocarcinomas are perihilar and distal extrahepatic, where we can intervene upon and help with EUS. Prognosis remains poor, especially with regional lymph nodes being involved. The diagnosis, as we all know, can be tricky. For distal biliary strictures, it's ideal to do EUS FNA first to diagnose as well as stage, and FNA, any regional lymph nodes that you see. And certainly if your needle enters the lumen of the bile duct, then stent. For perihilar strictures, again, remember not to biopsy this area if the patient might be a liver transplant candidate, but do FNA regional lymph nodes. For indeterminate biliary strictures, you can certainly try EUS FNA after initial negative ERCP, rather than just going to cholangioscopy. And intraductal ultrasound may be superior to EUS for T-staging, helpful in diagnosing these indeterminate biliary strictures, and not as helpful for nodal staging. So thank you very much for your attention.
Thank you very much, Linda, for that terrific talk. We are a little bit behind schedule, so I'm just going to call upon, we'll take questions right at the end, shall we, Mark? And shall we call upon Dr. Mustafa Ibrahim, the originator of EUS Confluence Days, to do his talk on hands-on training in FNA and FNB? Okay, so thanks to Professor Lee. We'll have a common discussion with the previous speaker. And now I'm very pleased to introduce Mustafa Ibrahim. Mustafa Ibrahim is going to show you live for hands-on session training. So Mustafa, you are with us?
Yes. Okay, good morning, everyone. So hopefully that you can see me and hear me now. So really, this is a new thing that during the COVID pandemic we were thinking with Professor Barthe that how to really change or adapt with the changes. So we thought that okay, we should put in the program a hands-on part. So this is the first time, I think, globally to do a virtual EUS hands-on training with this hybrid technique. So I'm happy today I have 2 sessions. This is the first session that I'm going to do FNB. And then in the afternoon, I will do another session for the cis drainage and axis. So first of all, to introduce my team, I'm working in the Roya Training Center with Salma and Rania supporting me today. I'm using the Fujifilm EOS scope, the 580 UT series with the SU1. We are going to use also, we have two models and two simulators. One of them is for FNB, where we have really a non-biological one of the interventions of my team to do an FNB model, a non-biological one. And we have another biological model where we have the cyst and really a true lesions, but biological one. So going to the procedure, as you know, we have two types of scopes. We have the radial scope where you cannot do biopsy. So I have the radial scope. If you can focus here on my hand. So
Mustafa, I cannot
see
you on my screen. I don't know for the other moderators if they have the full screen.
You should see me now.
But I have not the full screen.
You're on the small screen.
You're on a small screen. We need a large screen.
No, Nuran, could you put me on the big screen, please, Nuran? Okay.
Yeah, we're still seeing Mark's screen, actually. Yeah, we can only see you on the small screen.
Could you just we have control room? Could you please put me on the big screen, a full screen of me?
Full screen of with Mustafa. But
yes,
not
see me now?
Mark, I think you need to stop sharing your screen. Ah, okay, this is good. Yeah, you're on the big screen now, Mustafa. Yeah, you
okay. Are. So yeah, so as I said, we have two types of EOS scopes. The radial one, where we have here the probe here all through, which we can. It's more for diagnostic procedures, where you can see 360 the lumen, as you can see in the presentation, and we have the linear scope, where you have the probe in this part. And the main difference is that we can put a needle, or we can put an instrument here. So for the scope itself, it's the same like the ERCP scope. We have the normal elevator, which control the movement. So if you can focus here now. So you can have, this is the elevator where you control your movement. So I'm going to just introduce the needle. So we have previously we were using, I would say a couple of years ago, we were using this. This is the FNA needle. We were using this needle every day. This is the 22 gauge needle where we use it every day. But again, this is from Boston Scientific, the older expect needle, where we were using this, I would say, for all the biopsies or for the FNA. And then the paradigm shift happened where we have the new needle, the new FNB needles. And this is an FNB needle. This is the new acquired needle. And the main difference that here you have, I will try to show this to you, that we have at the tip of the needle itself. I will focus on it in 1 second. It's the light. So this is, if you can focus here, please. Yeah, you can see even now the animation of this. Okay, I think it's very small. So, but this is the typical. This is the tip of the needle. You can see it on the animation. So this is typically what I'm going to do. So it's not only that you are aspirating some cells, but you are taking really a core biopsy. So for the needle, I will explain a little bit of the steps. So the steps are. First of all, you have, this is the needle. You have two handles. You have two locks. So the first lock here, where you control the movement of the external sheath. You push and pull the external sheath, and this is the lock. And you have the second lock here, which you control the needle. So if I will put, I put it here, and then I will push like this. If you can focus here a little bit, yes. Yes, the other way, the other one, this one, yes. So if I push, I can push the needle out. So this is the second control. And then the third, you have here the internal, the stylus, where you have, this is the stylus, we're going to pull it. And last thing just to show you that is that we have the aspiration needle. So this is the aspiration syringe. We're going to put it to aspirate, and I will show different techniques. Normally, I think all the lectures cover this already. We have the aspiration technique versus the capillary technique, where we only pull back the style. So first of all, I will put my needle in the scope. I will show this is the needle. So you put it very like any instrument. And very important, you need first of all to fix your needle. So this is like this. Zoom out a little bit. No, zoom out, out. Yes, okay. So I will show. So first of all, we need to push our stylus like this. Yeah, zoom here. Yes, okay. So, and then you can control, you can see, you can control the movement of your needle by the elevator up and down. And then we will do this inside the simulator. Now, when I'm ready in my position, I will pull back the stylus a little bit like this. I will push my needle, and then I'm inside the lesion, and then I will start the technique of pushing back and forward to start aspirating and taking the biopsy. Meanwhile, Salma will be pulling the stylet to create the negative pressure inside the needle. And usually what I'm doing on my daily practice, I'm combining this capillary technique by pulling back the stylus, and then I will put the aspiration syringe. So I will start to go inside the simulator. So if you can see if you can put the EUS image, please. Okay, so this is an EUS image. Could you put my picture as a smaller image, please? Yes, perfect. So I will here, we have a lot of lesions, but I will select one of them. So this is one of our phantoms. So we have here very, you can see now the lesion is coming. So I will search. So yes, you can see now part of the lesion on the left picture. So first of all, I will centralize my picture like this. So you can see now the lesion. So the lesion is in the center of my screen. And second thing, I will show something also, one of the really, and this is a very special thanks to my colleague and friend and daughter, Nuran, that she really did a lot of work on this simulator. So we can even show elastography on this simulator. Yeah, you can see, I can put elastography picture, freeze. So you can see this, even this is one of the power of the SU1. We have elastography. So you can see now that the lesion, most of the lesion is green. So this is a soft lesion, not a hard one. Again, we are not here, we are inside the simulator, but this is just to show you the, so I will, if this is a real patient, I will try as much as I can to guide my needle through this bluish part. And this will be, I will say, this will be the very interesting part. So I will start, first of all, as I said, I will push my external sheath a little bit, just 1 centimeter. And I will centralize my picture again. And then I will I will pull back the stylus few millimeters. And you can see now the needle coming inside the lesion. You can see the needle inside the lesion now. And then I will start asking Salma to pull back very slowly the stylus while I'm taking the biopsy, going back and forward. And then we can do anything. We can do the fanning technique that I can move inside the lesion, changing my direction inside the lesion. You can see it. Yeah, yes, I will focus a little. I will just increase the dips a little bit like this. And then I will take, yeah, you can see now I will go like this to see the needle better. And then we can go. I'm very deep now. I pull back. And this is the typical way to do the FNB. And then I will stop inside the lesion, and then I will fix my needle. I will ask Salma to pull back the stylet, and then to connect the aspiration syringe. It's very important. I will show you, Salma will show you how to do it from the start. So the syringe comes inside like this. first of all, you need to close the valve, the three-way valve, and then to pull it back. And now you have negative suction inside. I will connect it to my syringe. Can you have an EUS picture again, please? Yes. And now, while I'm inside the lesion, so you can see my needle is really inside here. I will try to have a better picture like this. Yes. Okay, and then I will open the section, and I will start doing the same technique again, pulling back and forward, booking back, and pulling back, and then while I'm inside my lesion, I will stop. This is very important, not to have any gastric aspirate. So I will close the negative suction. I will remove this totally, pull back the needle, lock the needle, open my elevator, pull back the stylus, closing the second lock, and then I will remove the needle now. And then I will show you now how to put this on the slides. Yes. 1 second, just we will remove the needle. If you're Professor Barté and all the chairperson, if you have any question, I can hear you. If you have any question about what I showed before, I will show you how to spread the biopsy on the slides. We have any questions?
Just a commentary, Mustafa. First, the slow pull-out stylet technique. But actually, we have no scientific evidence to say that this technique is more for me, the simpler is the best. So my advice is, when you are a beginner, use the suction technique, because you are alone and you can do everything by yourself. And also my second advice, let the nurse screw this, because if you are doing that by yourself, yes, the risk of losing your target.
Yes, this is Professor. Yeah, this is exactly correct. Because what I did now, I was putting the syringe myself to the needle, and the problem on this, if you have a smaller lesion, you have the risk of pushing your needle outside or inside, more deep inside the lesion. So I will show you now how to put this. I will show it in 1 second. Give me yes. So the other technique, how to put the material out, I will show it in 1 second in the other needle. So we will take just 1 second. Okay, so when you are, I need just one of the nurses to help me. Okay, so when you have your could you focus on this on this slides, please, like this? So when you have the material inside, so now what I do, I will push my needle for 1 centimeter out, like this, yes. And then I will start asking while putting it like, yes, like this. Very good, thank you. And then while it is on the slide, I will start asking my nurse to push push the stylus, push the needle out 1 centimeter. Fix the needle, and then you start pushing. She starts pushing the stylus. While she's pushing the stylus, you start having the material here. I will show it in 1 second. And then normally what I do, I don't know, maybe in France is different, but what I do from when I came back, that I have always, and this is a very important question, Professor Barté and all the chairperson. Personally, when I return from Belgium, what I do, that I always have an on-site pathologist. I have an on-site pathologist that he will be with me. He will take the material, and then he will tell me, Mustafa, okay, we have enough material to stop the procedures. And normally, what he do, he will put the first three or four slides, and then he will take the rest of the material for cell block. And I don't know if I would like to hear also your comment, Professor Barté, on your daily practice. You do the same, or you do it, or in Marseille, you send everything to the pathologist. For me, I always divide my material between the slides and the cell block.
Okay, so Chris?
What we do is that we take just the first part of the aspirate if we can see some macroscopic tissue, and then that goes for the to the cytotech in the room, and the rest goes in there to smear to make sure that we are in the right place, and the rest of it goes into the cell block.
And Yuzuki, what are you doing?
We don't have always loads in a unit. So we ask only resectable pancreatic cancer patients for the loads. Otherwise, we just do FNA, and recently we do maybe 2 or 3 passes using the FNB needle, and we divide it into cytology and the histology.
Okay. So I will show you now, last thing in the first session, really how to, we have taken the material. So as I said, I have the needle 1 centimeter out. I will ask now Salma, could you focus on the slides, please? Yes. I will ask Salma first to push the material with the stylus. Yes, please, Salma. She's pushing the stylus.
And you are flushing with saline or with air?
First I put the stylus, and then I will flush after that with air on the slides. And if it's in the, so I will, now I have already some material. I don't know, it will be possible to I will push a little bit more with air. Okay. We have a very, I think, I don't know, you can see it or not, but I will search it. So if you can focus on my hand here. Yes, very good. So we have this material, this whitish material from inside. So this is typically what we take. And normally I will repeat this is one or two, 3 times till my pathologist say, okay, I have enough. And we are using here a 25 gauge needle. Yeah, this is an example of one of our where our on-site pathologists do. So he will stay with us. He will wait till such a picture that, okay, Mustafa, we have a very clear malignant cells. Okay, you can stop, and then I will take another one for the immunohistochemistry for cell block. So this is typically what we do.
Okay, so Mustafa, probably we need to start the overall discussion with the previous experts.
Yes.
And you, of course. So, Chris.
Thank you. Thank you, Mark. Well, we have some questions, I believe, from the audience, but while we're getting started, if I could ask Yusuke, in this era of much better CT resolution, and now with, as you mentioned, the criteria for borderline resectability, what proportion of your resectable pancreatic cancer cases actually, do the surgeons want EUS staging as compared to just FNB?
So I think CT scan is easier for surgeons to understand the vascular invasion.
Right, and they all get
EUS
CT
more,
anyway, right?
Yeah, right. So we are more focusing on the tissue diagnosis of EUS FNA rather than the staging by EUS.
Right, right. And
same
can I ask
in the US?
Okay, thank you. What about Linda? Is that the same for you as well?
Yeah, no, that's our experience as well with our pancreatic surgeons. Honestly, they don't really ask us or pay attention to staging that we do of pancreatic masses, and they're just so zoned in on the pancreatic protocol CT scan, looking to see if there's that 180-degree involvement or not. So that's honestly what they almost exclusively rely on for staging, and they just want us to do the FNB. We almost exclusively only do FNB of these pancreatic masses to try to get a diagnosis, and obviously if there's any lymph nodes, as well.
Yeah, I find that's really the what we do as well. Nobody's really interested in EUS staging anymore because the results are so close, and there's also the issue of inter-operator sort of variability as well. Okay, so some of the questions from the audience. Question from Dr. Sitaram in Nepal. Can we do EUS FNA for cholangiocarcinoma from gastric station? Linda?
Yeah, so so for distal cholangiocarcinomas, of course, that is typically something that you would be working from the duodenal bulb, perhaps even from the second portion of the duodenum, to try to carefully evaluate the entire extrahepatic bile duct. For something that's more proximal, I'll still be working from the bulb, and then you can work your way up into the antrum, where you may see and be able to access these lesions as well. So there certainly is a role for looking and assessing from the stomach for the more proximal lesions.
Okay, thank you, Linda. There's a question here, why do we need to do the first FNB needle passage in the lesion without the suction needle attached? Does it affect sample quality? I guess that's actually for Mustafa, I guess, but either of you could answer it. Linda, would you like to take that?
Sure. I mean, I think in terms of technique for the FNB needles, there is that theoretical concern if you have the suction on, it may lead to bloodier samples, and blood is always the enemy. And so there was kind of more enthusiasm for doing the slow pullback technique to exploit the capillary action with the stylet being slowly pulled back by your assistant. For me, and I personally haven't seen any studies, showing that, the suction is much worse with the FNB needle. There's studies, of course, looking at FNA. So for me, in my practice, I honestly, use suction as well as the slow pullback technique, just kind of depending on the day, honestly. And I personally haven't noticed any difference in diagnostic yield. Of course, if it looks like the specimens are very bloody appearing, then I'll, just don't stop suctioning and not use that to reduce the bloodiness.
And Linda, just a question for me. Do you have some data about the safety and the risk of seeding with FNB for cholangiocarcinoma?
Yeah, so I don't know if anybody else on the panel has seen data specifically with cholangio-CA and FNB needles. I personally haven't seen a lot of data on that. And, I think that the seeding issue is probably comparable to FNA. So again, with the perihilar lesions, if your patient might be a liver transplant candidate, you should avoid FNA or FNB of the perihilar area. For the distal, there's much less of a concern because obviously that whole area will be resected if they're undergoing surgical resection. In terms of safety, you know, my guess would be that the safety profile will be similar, extrapolating from all the other data, you know, that we have so far in pancreatic masses and other lesions.
Okay, thank you.
Thank you.
I have another question for Yuzuki. Oh, sorry, Chris. Just a short question for Yuzuki. I saw some slides about early pancreatic carcinoma. Have you some experience about screening for pancreatic cancer in family history of pancreatic cancer?
Yes, so it's not so common in Japan, but we have some patients. But so we combine EUS and MRI because those patients with a history of pancreatic cancer, family history of pancreatic cancer, they also have some cystic lesion.
Yeah.
So we combine EUS and MRI, maybe some alternatively. So I think that's the best option for those kind of high-risk patients.
Okay, so you are doing EUS screening for this kind of history.
Yes. Yusuke, how do you manage to persuade your patients to keep this ENPD drain in for 48 hours, right? For the screening for your stage 0 cancers? You know, will they all do it?
It can be possible only in Japan, I think.
I think so.
Yeah, that would never happen in the United States.
I know.
Yeah, definitely not in Singapore either. Can I ask both of you, Yusuke and Linda, do you do FNAs for or FNBs for patients preoperative you know, tissue diagnosis of pancreatic body or tail cancer? In other words, transgastric biopsies. Is that something which is acceptable in clinically, you know, in either of your practice settings?
This is an excellent and very difficult question to answer. I'm always doing FNA before surgery in resectable patient. Why? Because sometimes during the surgical procedure, the patient cannot be resected, and so the surgeon has to stop the surgery. And doing surgical biopsy is very dangerous with the risk of bleeding and fistula. So this is the reason for why I always do before surgery FNA in case of during the procedure unresectable tumor.
Yeah, it's a tough question, right? Because of the concern for seeding when you're doing FNA or FNB into the body tail, unlike in the head where that whole area is going to be gone anyway. And so I think, you know, for us, we do it for the same reasons, and also because sometimes, I mean, it's obviously maybe not as common, but you know, could the patient have autoimmune pancreatitis masquerading as a pancreatic mass? And so, and you know, I think all of us have had experience of sending patients to surgery because we're convinced they have pancreatic adenocarcinoma, but it ends up being AIP, and you're like, ah, shoot, you know. And
that's exactly it.
Yeah. So honestly, I think because of that, you know, almost always we're doing FNB to try to get that tissue diagnosis as much as possible, albeit, you know, understanding that small potential risk of seeding if it's an adenocarcinoma.
Yeah, we used to think that the incidence of seeding was very, very low, but 3% from that study, I think it was that Dr. Irisawa's group, you know, it's really very high. And if you're talking about T1 lesions being made unresected, being made incurable, that's really bad news for these individuals if you happen to be one of them. Do you think that the true incidence is actually anywhere near 3.7%?
Yeah, I think it looks too high for me, but I think it might be around 1%. And I think it depends on the biology of the primary lesion.
Right. I guess you won't know until you put your needle in there to
Right, right.
know for sure, right?
I have a practical question for all of you. Are you still doing FNA for pancreatic tumor, or are you doing only FNB?
Only FNB.
Only
FNB, yes.
Yeah.
Yeah, we only do FNB. And as I think as Dr. Nakai said, we do about 2 or 3 passes, with the FNB needle. If somebody comes in and already had a non-diagnostic EUS FNB, then I'll do more passes or have a cytologist in the room looking at the slides. But we don't have rows for all of our cases.
The same for us.
So the question for all of you: do you think that FNB could eventually make the cytotext role or the roles of role less prominent, or maybe even do away with it altogether?
Exactly. Yes, I'm fully convinced about that. With FNB, you do not need any more rows.
Go ahead, Linda.
Oh, no, I was just going to say that I agree. And we did do a study, not on FNB. This was an older study, randomized study comparing FNA, 7 passes to without rows, to FNA with rows. And it was a non-inferiority study. It was in digestive endoscopy. And we found that doing EUS FNA with 7 passes without rows was not inferior to doing EUS FNA guided by rows. Now, again, that's FNA, that's not FNB. But I agree. I mean, I think the role of rows continues to diminish with the advent of all the different FNB needles that we have.
Okay, so I think we have to close this very interesting expert roundtable. So thank you, Linda. Thank you, Yuzuki. Chris, I'll let you to conclude this session if you want.
Thank you, Mark. I think this has been a tremendous, discussion and talks from both all 3 speakers, and really there's been a lot of takeaways for me, certainly in all these practice settings. So thank you very much, everyone, and we'll move on to 3rd session, I guess now, Mark.
So now we have a break, and we will start again at 2:50 p.m. Okay, so break for everyone. So take a coffee, some rest, and see you later.
Okay. Thank you, everyone.
Thank you very much.
Bye-bye.
Thank you. Bye-bye.
See you later.
See you later.
Hello to all the 2020 EUS Confluence Day attendees. My name is Reddy Yakoba, and I'm the Manager of Global Education and Engagement with the American Society for Gastrointestinal Endoscopy. ASGE would like to show its support for this event, and I hope you're getting a chance to learn EUS from some of the best physicians in the world. A little bit more about ASGE. We are a network of over 14,000 members all over the world, and some of the benefits that our members enjoy are access to GI Leap, our online learning platform, in addition to our journals, GIE, Video GIE, and Journal Scan, and furthermore, some practice support and networking opportunities all over the world. We are planning on hosting and organizing a lot more events for our global members, so stay tuned for that. Another bonus video that ASGE would like to offer to the attendees of this event is some courses through GI Leap. If you go to learn.asge.org, you make sure to search 2020 International Sampler on the search bar, add it to your cart. You can create an account if you don't have one for free. Add it to your cart. Once you add it to your cart, make sure you use the promo code FreeVideo20 to reduce the price to $0. I hope you enjoy that. Some other resources that you can find when you visit asg.org, in addition to our GIE journal, is the Video GIE. Tons of video content there, and also some of our publications, our guidelines. Make sure to check those out as well. Anyway, I hope you are enjoying, and I hope you continue to enjoy the rest of this presentation, this webinar, and hope to see you soon in person. Goodbye.
The Axios Stent and Electrocautery Enhanced Delivery System is a precision device that creates a durable anastomosis between the GI tract and a target structure using the Axios stent. Axios is used under combined endoscopic and EUS guidance. Its electrocautery enhanced delivery system is designed to facilitate smooth, efficient access into the target structure without the need for prior dilation. The specially designed handle allows the interventional endoscopist to accurately deliver the Axios stent while maintaining control of the echo endoscope. The monopolar plug on the top of the handle provides a connection with the electrosurgical generator. Numbered arrows on the handle correspond with the steps of the deployment procedure. The catheter has a hydrophilic coating to reduce friction. The black catheter shaft marker indicates proper positioning of the Axios stent during deployment. Radiopaque markers aid with fluoroscopic positioning of the catheter. The small diameter wire on the ceramic tip of the catheter creates a high current density that allows for an efficient cut. The stent is available in two sizes, 10 mm by 10 mm and 15 mm by 10 mm. The stent length is measured between the two stent flanges. The Axios stent has a large lumen diameter designed to optimize drainage. Its dual flange design prevents migration and maintains tissue apposition. The Axios stent is fully covered to prevent leakage of fluid, resist tissue ingrowth, and enable ease of removal. Wet the Axios catheter with sterile water or normal saline to activate the hydrophilic coating. Then insert Axios into the working channel over a previously placed 035 guide wire and secure the handle to the endoscope by rotating the lure fitting clockwise onto the scope hub. With the electrosurgical generator powered off, connect the active cable to the monopolar plug on the handle of the Axios. Power on the electrosurgical generator and ensure it is on the recommended pure cut or auto cut setting. Step 1. Under EUS guidance, unlock the catheter lock and advance the black catheter control hub until the catheter is seen using EUS. Verify the desired settings on the electrosurgical generator. Energize the device and continue to advance the catheter control hub until the catheter is visible in the target structure. Note that temporary interference of EUS imaging may occur during activation of the cautery tip. Normal EUS operation will resume immediately after deactivation of the cautery tip. Lock the catheter lock. Power off the generator and unplug the active cable from the Axios handle. Step 2. Deploy the first flange of the stent. Remove and discard the yellow safety clip on the stent deployment hub. Unlock the stent lock and slide the stent deployment hub upwards until the stent deployment hub locks into place at the white line next to the number 2 arrow. Step 3. Pull the endoscope back slightly in order to directly visualize the catheter shaft in the GI tract. If you are able to see 2 to 3 millimeters of the black catheter shaft, proceed to step 4. If not, unlock the catheter lock and slide the catheter control hub upwards until at least 2 to 3 millimeters of the black catheter shaft marker is visible in the GI tract. Then, lock the catheter lock. This indicates that the Axios stent is correctly positioned for the final stage of deployment. Step 4. Unlock the stent lock and slide the stent deployment hub upwards towards the number 4 arrow until the stent deployment hub meets the top of the handle and the second flange of the Axios stent is deployed and visible in the GI tract. Remove the Axios delivery system by rotating the lure lock fitting counterclockwise and gently pulling the device from the scope.
Mais les essais de moto, c'est moins spectaculaire que pour la voiture. Par contre, la course, c'est plus spectaculaire que la voiture. Je dois dire, capable de réaliser de très belles performances.
The Acquire Endoscopic Ultrasound Fine Needle Biopsy device is a new biopsy device designed for the targeted sampling of submucosal and extramural lesions in the gastrointestinal tract. It's able to do this through the accessory channel of a curvilinear echo endoscope. The system comes with a handle and customized sheath similar to our Slimline family of needles, and it provides the same great performance you've come to expect from our products. What differentiates the Acquire FNB needle tip from FNA aspiration needle tips is its cutting surfaces. While other needles may only aspirate cells and perform minimal tissue cutting, the design of the Acquire FNB needle provides an increased number of cutting surfaces, thus increasing the chances of getting a visibly larger tissue sample for histology. This tip design is similar to percutaneous biopsy needles used in interventional radiology. The Acquire needle also has custom sheath sizes, designed to improve passability and help advance the needle out of the sheath. The 3 needle points are designed to afford greater control at the puncture site. They also provide stability to the tip at all times, allowing for easy penetration. To facilitate puncture and potentially minimize tissue tearing, the tip of the needle is electropolished, a manufacturing process that removes all imperfections. Aided by aspiration, As tissue moves through the needle tip, it's pushed into 3 symmetrical cutting heels. These are fully formed to maximize sharpness and cutting capabilities. In addition, these heels cut tissue from 3 different angles, making a more circular cut before it's pushed into the needle. Compared to the FNA needle tip designs, the Acquire needle is designed to capture a larger volume of tissue with minimal fragmentation. Along with the Acquire's optimized tip design, the system is also made of cobalt chromium, which delivers superior penetration and leads to less needle deformation than stainless steel alloys. The Acquire fine needle system features control zone and lubricant on the handle for actuation, making it one of the most versatile biopsy devices on the market.
Hello to all the 2020 EUS Confluence Day attendees. My name is Reddy Yakoba, and I'm the Manager of Global Education and Engagement with the American Society for Gastrointestinal Endoscopy. ASGE would like to show its support for this event, and I hope you're getting a chance to learn EUS from some of the best physicians in the world. A little bit more about ASGE. We are a network of over 14,000 members all over the world, and some of the benefits that our members enjoy are access to GI Leap, our online learning platform, in addition to our journals, GIE, Video GIE, and Journal Scan, and furthermore, some practice support and networking opportunities all over the world. We are planning on hosting and organizing a lot more events for our global members, so stay tuned for that. Another bonus video that ASGE would like to offer to the attendees of this event is some courses through GI Leap. If you go to learn.asge.org, you make sure to search 2020 International Sampler on the search bar, add it to your cart. You can create an account if you don't have one for free. Add it to your cart. Once you add it to your cart, make sure you use the promo code FREEVIDEO20 to reduce the price to $0. I hope you enjoy that. Some other resources that you can find when you visit asg.org, in addition to our GIE journal, is the Video GIE. Tons of video content there, and also some of our publications, our guidelines. Make sure to check those out as well. Anyway, I hope you are enjoying, and I hope you continue to enjoy the rest of this presentation, this webinar, and hope to see you soon in person. Goodbye.
So
The Axios stent and electrocautery enhanced delivery system is a precision device that creates a durable anastomosis between the GI tract and a target structure using the Axios stent. Axios is used under combined endoscopic and EUS guidance. Its electrocautery enhanced delivery system is designed to facilitate smooth, efficient access into the target structure without the need for prior dilation. The specially designed handle allows the interventional endoscopist to accurately deliver the Axios stent while maintaining control of the echo endoscope. The monopolar plug on the top of the handle provides a connection with the electrosurgical generator. Numbered arrows on the handle correspond with the steps of the deployment procedure. The catheter has a hydrophilic coating to reduce friction. The black catheter shaft marker indicates proper positioning of the Axios stent during deployment. Radiopaque markers aid with fluoroscopic positioning of the catheter. The small diameter wire on the ceramic tip of the catheter creates a high current density that allows for an efficient cut. The stent is available in two sizes, 10 mm by 10 mm and 15 mm by 10 mm. The stent length is measured between the two stent flanges. The Axios stent has a large lumen diameter designed to optimize drainage. Its dual flange design prevents migration and maintains tissue apposition. The Axios stent is fully covered to prevent leakage of fluid, resist tissue ingrowth, and enable ease of removal. Wet the Axios catheter with sterile water or normal saline to activate the hydrophilic coating. Then insert Axios into the working channel over a previously placed 035 guide wire and secure the handle to the endoscope by rotating the lure fitting clockwise onto the scope hub. With the electrosurgical generator powered off, connect the active cable to the monopolar plug on the handle of the Axios. Power on the electrosurgical generator and ensure it is on the recommended pure cut or auto cut setting.
I think we are on time.
Under EUS guidance, unlock the catheter lock and advance the black catheter control hub until the catheter is seen using EUS. Verify the desired settings on the electrosurgical generator. Energize the device and continue to advance the catheter control hub until the catheter is visible in the target structure.
So for Royatem, we need to start, okay?
Okay. Good afternoon. I'm Bahattin Çiçek from Acıbadem University, Istanbul. There are some changes in this section. We will start with Dr. Pradermchia Kamkam from Thailand. His topic is can endoscopic ultrasound.
Hello.
Good afternoon. Good afternoon.
How are you, Prader? Hi.
Hi, very good. How are you?
We can start with title Endoscopic Ultrasonography Replace ERCP for Malignant Biliary Distal Biliary Obstruction. Please, Dr. Kamkam.
Okay. All right. Can you see my slide and hear my voice now?
Yeah. Yeah. Perfect.
All right. Nice to see everyone again. And then I have about 20 minutes. And thank you very much for the organizing committee for inviting me to talk about EUS Guided Drainage versus ERCP. And my talk today is about can we use EUS biliary drainage as a primary biliary drainage method for malignant distal biliary obstruction. So if you look at this slide, then you will see that in some procedure, ERCP is still mastered. And in some procedure, EUS still mastered for those procedures. However, in some procedure, we can combine between ERCP and EUS. Also in some procedure, we have to think that which in the situation is this good for ERCP or is this good for the EUS. So let me talk about this slide a little bit. This is a role of the ERCP in 2020, in my opinion. I think that the diagnostic cholangiogram is not commonly used indication for ERCP at this time in 2020. But ERCP is still there because ERCP has very good and clear and much development for cholangioscopy. And this is the future of ERCP because it can provide us virtual diagnosis of all the findings in the bile duct, and also it can provide us the tissue diagnosis under a direct guidance of the image. And also ERCP is a big step for the biliary drainage. And at this time, we start to do some ablation for bile duct tumor as well. So ERCP is still there, and old friend never die for ERCP, that I like to say. How about EUS in 2020? So all the basic EUS everyone know very well: pancreas stuff, bile duct, and subcutaneous region, luminal cancer staging. And for advanced EUS, at this time, it is EUS guided drainage, including drainage of pancreatic fluid collection, biliary drainage, pancreatic duct drainage, gallbladder drainage, pancreatic duct drainage. Professor Isayama, my friend, will talk about this later. And also EUS can be used for guidance of the ablative therapy, IFA, alcohol ablation, duct livery. Professor Bartlett has a nice work on the IFA for cyst and neuroendocrine tumor recently. And today my talk is about EUS and as a primary biliary drainage. So then currently accepted indication for EUS biliary drainage at this time is failed ERCP in experienced hands, or surgical outer anatomy in accessible papilla from duodenal obstruction. And sometimes we like to convert it from external biliary drainage to internal biliary drainage. So that's another indication. It's interesting that EUS biliary drainage might be another alternative, or even, probably procedure of choice in some situation for primary biliary drainage in case that require biliary drainage in the future. However, in some situation, EUS is not possible at this time, and then we need the still need the ERCP. And that are those patients who have ascites, coagulopathy, or patients who have too advanced disease on the high ECOG score, pregnancy, intervening tumor, or something. So, types of the EUS biliary drainage procedure. For transperipheral route, it can be anti-graft stenting, can be rendezvous. Transmural route generally is CDS, HGS, and HDS, as you see in this cartoon. This is HGS, this is CDS, and this is hepaticoduodenostomy. They are all transmural EUS biliary drainage procedure that being done at this time. So how I select my patients and how I can assign specific EUS biliary drainage procedure to them. I will start with when I see patient with biliary obstruction, I will see the patient and evaluate the patient and classify the patient into, the first one is unresectable malignant biliary obstruction. The second one is malignant but resectable biliary obstruction. In the second option, that resectable malignant biliary obstruction, I wouldn't consider EUS biliary drainage. It depends on surgeon. If they want to do PTPD because they don't want us to touch around the ampulla area, that's fine. We just let them do and go ahead with that. And for benign biliary obstruction, I think that in the future, probably information will come more and more. But at this time, information of using EUS biliary drainage for benign biliary obstruction is very small at this time. So today we will focus on unresectable malignant biliary obstruction. And in unresectable biliary obstruction, actually it's been divided into distal biliary obstruction and malignant and hilar biliary obstruction. And most of papers of EUS biliary drainage today is we focus on distal biliary obstruction, only few that focus on hilar biliary obstruction. But anyway, today we'll talk about distal biliary obstruction. So in malignant distal biliary obstruction, for transperipheral route, what we can do anti-graft stenting. We can do rendezvous procedure. In anti-graft stenting, actually I prefer over rendezvous, even though literatures at this day show impressive information of rendezvous. But in my idea, EUS anti-graft stenting for me is a little bit more convenient because it's single-step procedure. We don't need to change from echo endoscope to the ERCP scope. And anti-grade stenting can be applied even in patients who have supraempyreal obstruction from distal biliary obstruction. Wrong rule, you need a little bit of very good skill assistant to help you to continue the procedure, to manipulate the guide wire going to the desired directions. And yeah, so in my opinion, if I need to do transbiliary route for EUS biliary drainage in distal biliary obstruction, I would choose anti-grade stenting. And this is example of the video showing the anti-grade stenting. I punctured into the left interstitial bile duct. Typically for anti-grade stenting, we choose segment 2 and we pass the guide wire in, and then finally we pass the stent through across the stricture, and we deploy the entire stent under the fluoroscopic guidance, and then finally when the stent is in appropriate press, then it can drain the bile fluid effectively. The benefit of anti-grade stenting, we can avoid pancreatitis, certainly, right? Because we don't touch the pancreas at all. So how about the transmural route? In the transmural route, it could be extrahepatic bile duct, which is choledochordinostomy or CDS, and intrahepatic approach is HGS and HDS. For CDS, it's extrahepatic approach. Actually, in my idea, comparing with intrahepatic approach is less technical demanding, but it's not suitable in patients who have distal biliary obstruction, but the obstruction is so high. So then sometimes doing CDS in that situation, it will be difficult. And the most appropriate stent for CDS at this time, I would prefer lamps if possible, because it has anchors on both sides. It can prevent the migration. And to my opinion, hot lamps will be easier than cold lamps for the CDS. Certainly in small bile duct, fully covered stent can also be used, but plastic stent, I think a little bit difficult to be used for the CDS at this time. For HGS and HDS, it's possible even in patients with high level of distal biliary obstruction. And in my, to my knowledge, the most appropriate stent at this time is hybrid stent. And the second most interesting one probably the plastic stent invented by Takao. And for hepaticoduodenostomy stent, in my press, we still use fully covered for that. So this is one case that demonstrates that ERCP is not possible, because I'd like to thank my junior colleague, Dr. Thanawat, for editing this video. In this CT scan, you will see that the patient has distal biliary obstruction from periampere tumor, and we plan to do ERCP. But once we dropped the scope in, we found that the mass is too big, and then ERCP is not possible. And also this mass caused duodenal obstruction. We try ERCP for a certain period of time, but it looked like it's impossible. So then what we do, we change the procedure to choledochordinostomy. We identify the bile duct, which is larger than 13 millimeter in diameter. So then we decide to use the needle plugging in, and then sequence cystotome to dilate the tract, and also follow with the 4 millimeter hurricane balloon to dilate the tract. And then finally, we place the cold system lamps to be a choledochordinostomy stent. And then the bile can be drained through this CDS. But the patients still have duodenal obstruction. So then we have to start the second procedure. After we finish the CDS, so then we go to EUS guided gastrojejunostomy. We do under nasopharyngeal tube, helping us by feeding all the fluid into the small bowel, and we use the hot system spassus to be the lamps for this gastrojejunostomy. So and the procedure run very well, and then we can have a small bowel fluid through the hot spassus system. So this is a position of the CDS stents, lamps, and this is a gastrojejunostomy stent. And the patient went very well after the procedure. Today is just maybe 10 days after the procedure, he can resume food since second day, and now bilirubin came down. So this procedure ran very well. So you see that in this kind of case, ERCP is not possible. And if we use EUS biliary drainage, we not only drain the bile duct, we can also drain, fix the problem of duodenal obstruction as well. So then to my idea, so I think that in unresectable distal biliary obstruction, if the level and location of the obstruction is low distal biliary obstruction, and with the supra and peridural obstruction, only antegrade stenting and HGS is possible. But if no supra and peridural obstruction, all kinds of transpleural biliary drainage and also transbiliary biliary drainage is also possible. But if the level of the obstruction of distal biliary obstruction is high, so then the possible procedure will be only the hepaticogastrostomy, antegrade stenting, or round the wound procedure. So then if we look at the review that corrected all research that compare between EUS biliary drainage versus ERCP, we could identify around maybe 8 to 10 papers, and 3 of them are papers with a large number of patients. They include from Bang in 2018, from Pancreatic, and for PAC, all 3 papers are very interesting. So if we look at these 3 papers from Bang, from Pancreatic, and from PAC, the maximum number came from Korea, from Pancreatic and his group. And then it's a multi-center prospective non-inferiority trial, and the primary outcome is technical success. And if we look at the result of technical success, EUS versus ERCP, it seems comparable for all these 3 studies for 2 procedures, EUS versus ERCP, more than 90%. Clinical success also more than 90% for both procedures and all 3 studies. For adverse events, it's interesting that there are some, not similar outcome. From Bang, look like that EUS BD has a little bit higher complication rate, but whereas from PIKE, which has the highest number, ERCP has much higher complication and probably too high. For people who do ERCP for a long time, 20% of complication for drainage of distal biliary obstruction. I think everyone would agree that it's probably too high, but anyway, the result of the study showed that. And stent patency rate look like that EUS biliary drainage is better. It's 85 versus around 50%. And patency time, look at the PIKE study, is 200 days versus 160 days. So it's again, and reintervention rate from PIKE study, we'll see that EUS biliary drainage has win again, 15 versus 43%. So then, and several meta-analysis and systemic review has analyzed these 3 papers. I choose one to show you. This published in 2019, and all those 3 studies published in 2018. And if you look at these 3 parameters, including stent dysfunction, EUS biliary drainage is better than ERCP. For post-procedure pancreatitis, again, EUS is better than ERCP, and also for the tumor in growth as well, that EUS is also better than ERCP. So that's current information that we have comparing between EUS biliary drainage versus ERCP in distal biliary obstruction. So I like to show you one case in our practice. This case probably maybe 1 or 2 months ago. The patient has bismuth 1 obstruction and has undergone bilateral ERCP to fix the bismuth 1 biliary obstruction. But unfortunately, probably 2 or 3 months later, the patient has recurrent biliary obstruction. So then we change to the combination of hepaticogastrostomy and ERCP stent. But again, a few months later, there was some recurrent biliary obstruction. So then we evaluate both stents. So in the first stent that we evaluate is ERCP stent. In the ERCP stent, we look at this CT scan. We found that HGS stent and ERCP stent, and this is the ERCP stent. When we inject the dye in, we saw the tumor in growth, some partial block in the ERCP stent. So if we use the endoscopy, we can see the tumor clearly through the ERCP stent. So then we went back to the hepaticogastrostomy stent. In the hepaticogastrostomy stent, we inserted our catheter through the HGS stent and did the cholangiogram. And then the cholangiogram through the HGS stent show patent HGS stent, as you are seeing here now in the video. No obstruction of the HGS stent. The bile can flow very good. And so then in this case, it's clearly that recurrent biliary obstruction in this case who has both ERCP and HGS stent, the occlusion occur in ERCP stent, not in the EUS stent. So very interesting to compare this information in more systematic studies. So my conclusion is that I like to draw the conclusion from a paper of Bang in 2018 that at this time from randomized control trial, EUS biliary drainage are comparable to ERCP in terms of technical and clinical success. However, EUS biliary drainage has lower rates of adverse events without post-procedure pancreatitis and also higher rates of stent patency and less intervention. So probably it will be a good candidate. Anyway, the largest study from PIPE were commented on high rates of post-ERCP complication. So at this time, to my knowledge, I think that there are two ongoing multi-center randomized control trial to compare between EUS biliary drainage and ERCP and EUS biliary drainage as a primary biliary drainage method. And the one that I was involved is the DRCBDS trial. And I hope that when results from this big multi-center study come, we will have more answer on this issue. And thank you very much for your time. And if you have any question, I'm pleased to have a question at the end of Professor Isayama talk. Thank you.
Thank you, Professor Pradhamshe. So we jump to the next lecture performed by Professor Isayama and jump from the biliary drainage to the main pancreatic duct and pancreatic drainage, and we will perform the overall discussion at the end of the second lecture, if you agree. Okay, so Professor Isayama, it is your turn to perform the lecture. Welcome.
Okay, thank you very much for kind introduction. So I'm very happy to
just welcome for Marc Marté. Just welcome for Marc Marté, Hiroyuki.
Okay.
Hi.
Okay, can I start? Okay.
Yes.
Hey, thank you very much. I'm Isayama, Hiro Isayama from Juntendo University. I'm very happy to present my work about interventional EUS. This time, I will talk about interventional EUS pancreatic intervention. So I want you see my presentation very well. Can you see?
Yeah.
Is it good?
Yeah. Put it in the full screen, maybe.
Okay. Oh, it is.
Can you put it in full screen? Yes, perfect.
Okay, it's okay. It's okay.
Okay.
So today's my topic is pancreatic duct interventions. So it is still only expert can perform this procedure, because I think that this procedure is most difficult in the interventional EUS now. So this slide shows the kind of the procedures. So EUS pancreatic drainage, EUS rendezvous, and other category is interventions through the EUS PGS, so created anastomosis. So you can see the EUS guided, sorry. So you can see the EUS guided pancreatic gastrostomy. So this type of the drainage, both external and external drainage. And the EUS randomly assisted pancreatic drainage, the internal drainage. So from the papilla. So, and as you know, it is a very well-known EUS guided rendezvous technique. It is when we fail to cannulation. The other category, intervention through the EUS PGS. So stricture management, stone management, and the POPS. I will show you the some VTL later. So indications. So need of pancreatic drainage. Patient status recurrent pancreatitis, symptomatic chronic pancreatitis, pseudocyst and fistula due to a pancreatic leakage. Cause is MTB, MPD stricture, anastomotic stricture, and the other one is antivism. So failed difficult pancreatic access. Anatomical status, inaccessible major minor papilla or anastomotic site. So mainly surgical altered anatomy, or sometimes duodenal obstruction. So the procedure status cannulation failure, and the other one is a fail to pass MTB stricture. Maybe some chronic pancreatitis, difficult to pass the stricture. Then we perform the ESPD. This is a contraindication. So patient status, coagulopathy, severe sickness, anatomical status, invisible and non-dilated pancreatic duct, and a long distance and unavoidable large vessel in the puncture route. Most important thing is the operator's status. So non-expert cannot perform the ESPD. So I will present 3 sessions. First one is the EUS pancreatic drainage. So this is our equipment. Both Olympus, one is a Fujifilm UG580. But recently, we mainly use Fujifilm scope because this scope is dedicated for interventional ES, designed by me. So look, so this scope, so acutely angled by large wheel, and also acutely angled by so elevator. So we can puncture the wide range, and also oblique viewing is very good for the interventional EUS. So we've used mainly 90 gauge EG shot 3, and we use mainly 025 guide wire. But recently, the 018 Olympus guide wire I used, it is very good. So this type of guide wire can use 22 gauge needle. It is easy to puncture. Maybe this guide wire will be available soon. Guide wires, so mainly I use an 025 Vigiglide. So maneuverability is very good, and the torqueability, but sometimes supportability is insufficient. At that time, I select a lever wave, so harder guide wire, both 025 and 035. Dilators, there are many dilators, and we only Japanese has EUS biliary dilator, very, very thin mechanical dilator. And also we have a very thin tip quarterly dilator, fine 025. So those are very useful to perform the intervention ES, especially EUS PD. So this slide shows the EUS biliary dilator, but this slide shows the pancreatic drainage. So the Dr. Itoi's group comparing the quarterly and the mechanical dilator, it means for EUS dilator. So technical success is very high in both groups, but no bleeding in a mechanical dilator. So our strategy, firstly, performing the mechanical dilation. If failed, so switch to the cautery. So balloon catheter also are very important to insert devices. So minimum dilation is required. So according to the following insertion devices. So also it is Japanese dedicated device, LEN, very thin tip balloon catheter. If we don't have LEN, so hurricane balloon dilator is very good because of the pushability is very good. So frequently we use double pigtail stent. So, but sometimes it's very difficult to insert the tip of the pigtail, so easily to bend. So the before insertion, sufficient dilation required, and we always insert a double pigtail along the 035 guide wire, very hard time. And sometimes it's really difficult to confirm the distal part. Then we totally push the stent into the organs. So then we mark the distal part, so fully. And this one is a lower one is a stent with a pulling back function. So it is a very safe procedure. So this is a plastic stent. So it is a normal stent, and the right side is a very special dedicated stent for the interventional EUS. Dr. Itoi developed this one. Then this stent named IT. IT means Itoi Takao. So it is a very easy to insert from the puncture route. So this is our selection criteria of the plastic stent. So external drainage, place a stent in the duct or cavity, very thin duct, use a straight. But a large duct or cavity or internal external drainage through the papillary anastomosis, a tip of the stent into the duodenal jejunum, we use a double pigtail stent. So this slide shows the equipment for the double guide wire technique. So these dilator, brushing strategy brass, Haber lamp catheter, and we have a double lumen catheter for the 025 and 035 guide wire. So Dr. Nakai published this article using the uneven catheter. Uneven means one lumen for the 025, other lumen 035. It is a very beneficial for the USPD. After the double guide wire insertion, the scope stabilized. And if the stent insertion failed, so other guide wire remaining, it is a safety guide wire. So I will show you our BTL, so ESPD. So we puncture the PD with a 90 gauge needle. So penetration, because mainly so target is very hard. 025 guide wire insertion. So this time we successfully pass the stricture, the anastomotic stricture. Now I try to dilate puncture route with the ES dilator. Tip is very thin, and I gradually change the scope position, and finally succeeded. And the balloon dilation, now insertion of the double lumen catheter, and introduce the 035 guide wire. Now we insert a double guide wire. Subsequently, try to insert a double pigtail stent, because one side you can see the pigtail in a jejunum, other side in a gastric. It is a very safe, no migration procedure. So Dr. Nakai's review. So the success rate of the ESPD is less than 80%. So it is relatively lower than the ESBD. But the ESPD very high, but the ES rendezvous very low. So it is very difficult to manipulate a guide wire. So this is our result experience. We experienced 20 cases these 2 years. So mainly tied to PDS, Pancreatic duct stricture, or GOO. Other one is a surgical altered anatomy. Success rate is very high, 95%, and a very high clinical success rate. 80% succeed to pass the stricture or anastomotic stricture. And a very low acceptable adverse event rate. Okay, move to the rendezvous. I will show you some VTL. This case, so fail to pass the stricture from the papilla. So we puncture the body of the pancreatic duct. We carefully manipulate the 025 guide wire and relatively easily pass the stricture. So sometimes from the papilla, very difficult, but the switch to the ESPD, easy to pass the stricture. And insert the catheter and pass the stricture. Sometimes very difficult to pass the stricture. But we bring back the guide wire at the mouth of the patient. It is a very strong power. And switch to a guide wire insertion into the pancreatic tail and withdrawn initial guide wire. And finally, successfully place the pancreatic stent from the papilla. So internal drainage. Okay. Good. Other one is division case. So it is recurrent pancreatitis, failed cannulation via accessory papilla, and failed EUS rendezvous in another institution. So because of the very thin pancreatic duct, I tried to puncture with a 90 gauge needle and succeeded in a third time. And manipulate a guide wire carefully, and finally succeeded to insert the guide wire into the duodenum. And finally, we insert a catheter from the accessory papilla. So, and switch to the guide wire into the tail area. And finally, so we can successfully completed the procedure. So accessory papilla sphincterotomy and temporary pancreatic duct stenting. So EUS rendezvous is a very useful procedure if they fail to pass stricture or fail to cannulation. Okay. So next topic is the intervention through the EUS PDS. Oh, so sorry, stricture. Sorry, STOMI anastomosis, created anastomosis. So this VTL. So I'm performing the EUS PGS. So firstly, so I try to pass the stricture. You can see the stones and the stricture at the pancreatic head, but fail to pass the stricture. I change the mind and insert a guide wire, so as long as possible, and insert a hard portion at the puncture root, and try to dilate puncture root with a cautery dilator. So, and finally, I insert a plastic stent. And after the insertion of the pancreatic stent, so we perform the ESWL to crush the stones. And next VTR, the right side. So along the stent, we insert a guide wire and try to pass the stricture. So you cannot see the stones because we successfully performed the ESWL. And finally, we can switch to the transpapillary drainage. So after the maturation of the EUSPD anastomosis, we can perform the many procedures. So this VTR show the EUS rendezvous after the EUSPDS. So this is a multiple plastic stent placement. So there is a stricture at pancreatic anastomosis. So initial ESPD, we successfully passed the stricture at the anastomosis. But we want to dilate stricture more. So then we decided to insert 2 plastic stent from the ESPGS, pancreatic gastrostomy. So initially dilation of the stricture and pancreatic wall, ductal wall, and gastric wall. Finally insert 2 stent. After the 2 stent placement, the anastomotic site, both anastomotic site dilated. So it is a covered metallic stent placement. It is also useful to dilate anastomosis, PG anastomosis. So created anastomosis, we can insert spyglass. So Todd Ballon reported spyglass procedure to crush the stone with EHL. So we also insert PG spyglass through the PGS anastomosis. So you can see the white stone. So and finally, we successfully push out the stone with the scope. And after the stone removal, we place 2 stents. And finally, we place 3 stents and place for the 1 year. And finally, we retrieve the stent. So stricture management. So and POPS. So this is a IPMA at the anastomosis site. So it is difficult to remove the stent because there is a IPMN at the stricture. So now we are keeping the PGS route, and every 4 months we perform the spyglass examination for the IPMA. So other one is so look, there are many sutures around the stricture. So we discussed with the surgeon. So surgeon told to us these sutures can be moved. So then we try to remove the sutures with a spy bite. So grasp the suture and pushing the spy grass to remove the suture. So one by one, we grasp the suture, and finally, but during the procedure, we aware the small hole. So there is a small perforation after the sutures removement, but place a stent. So no severe complication occurred, and finally, this patient placed 3 stents, and after 1 year, successfully remove the stents after resolution of the pancreato-jejunal anastomotic stricture. So this slide shows our experience to the POPS spyglass through the EUS PGS. 12 cases we performed. So most of the case benign fibrotic stricture, and the 3 cases recurrent IPMA. So we performed the EHL 2 cases, and only 1 mild pancreatitis occurred. So I will show you the one troubleshooting case. This VTR presented in Asian endoscopic cup in the APW in Kolkata. We got a special prize by Koto Mishima, my junior doctor. So 2 stent placed, 1 pigtail and 1 straight stent. And the straight stent completely migrated into the pancreatic duct, and the proximal side go into the tail area. So how to retrieve the migrated stent? So my plan is the insertion of the POPS and the push out of the migrated stent into jejunum, and finally remove with the spybite. So initially we insert a guide wire beside the stent, and remove the double pigtail stent, and insert a spyglass via EUS PGS. So we can see the stent in both pancreatic duct and also in jejunum, but we cannot see the proximal side because the proximal side in the tail area. So we insert a guide wire under spyglass endoscopic view, and successfully insert a guide wire from the flap. And after the insertion of the guide wire, we push the spyglass into the jejunum. So more and more pushing. The straight stent gradually move to the jejunum, and finally the proximal side go into the jejunum. So subsequently, we putting back the POPS spyglass, and insertion of the spy snare to catch the stent in the jejunum. So we try to catch the proximal side, so tip of the stent with the spy snare to remove the migrated stent. So you can see the proximal side, so very good. And finally, we successfully grasp the tip of the stent, and withdrawn the spyglass with the migrated stent successfully. So after this case, we place we do not place a straight stent. So only double pigtail stent we placed. So we are afraid of the straight stent, so migrated into the pancreatic duct. So this is our conclusion. So ESPD and the rendezvous effective in salvage therapy if the ERCP failed or difficult. Dedicated devices are required for the ES pancreatic duct intervention. And the classic stent with piggyback in function was mandatory. And after maturation of the fistula, we can perform the similar as transpapillary procedures. Thank you very much for kind attention, and thank you for the my junior doctors. I finished my presentation. Thank you very much.
Thank you for this very impressive presentation, especially with the transgastric spice scope approach, which is very original and seems to be very efficient. So maybe I will start the discussion, and I will try to have some questions for you, and maybe we will switch to the biliary duct drainage again procedure with all panel experts. So what is the time do you have between the first procedure, I mean the procedure to perform the access, and maybe the second interventional procedure, especially you show us the use of spice scope for the maturation of the tract. How many time do you wait?
Okay, can I explain? So I performed the spice scope examination or procedures, both EUS guided pancreatic duct drainage or biliary duct drainage. So mostly, so minimum duration is 2 weeks. So, but 3 weeks or more is safe. So because I experienced 1 or 2 cases after the 2 weeks, the leakage will be occurred. So then 3 weeks is safer, I think. But most important thing is before insertion of the spyglass, so insertion of the guide wire and the catheter insertion, and gradually inject contrast around the puncture route. So if we observe the leakage of the contrast media, so we performed only a stent exchange and wait 1 or more, 2 or more weeks. But no leakage, we can insert spyglass through the created anastomosis. We think these are matured, we think.
Je crois there is a question for Prader. Prader, you have a question, a chat question.
Sure.
Question is, what is the minimum CBD diameter you need to deploy lamps to create a choledochoduodenostomy?
I think 13 millimeter. 13 millimeter will be safe. Will be safe. But if you want to use lamps even in the smaller than 13 millimeter in diameter, you need a little bit stronger guide wire to manipulate the direction of the lamps that you place. Otherwise, if it's smaller than 13 millimeter in diameter, when you deploy the farther end of the lamps, sometimes the farther end is not in the bile duct. It's in between the bile duct and in the small bowel, and that will cause trouble. So if you do in the smaller than 13 millimeter, you have to be very experienced, and you've done so many cases before. Yes. And can I have a question for Professor Isayama?
Yes.
Yes, sure.
Sure. Very nice talks always, my professor.
Thank you very much.
Yes. So you have done so many cases of pancreatogastrostomy, and because pancreatitis sometimes is chronic pancreatitis, so problems still remain. So then in any cases that you observe permanent fistula between pancreatic duct and stomach, without continuously using the stent to keep the tract open.
Okay, thank you very much. Very nice, very important question. So our final goal is resolution of the stricture at the pancreatic duct or anastomotic site. If the strictures are resoluted, so we retrieve the stent. So we retrieve the 5 or more stent, and but most of the case, so fistula closed. So it is very difficult to maintain the EUS PGS, because I think that if we fail to resolve the anastomotic stricture or pancreatic stricture, the pancreatic juice go to the stomach, then we can keep the anastomosis. But we successfully resolve the stricture, so pancreatic juice go to the jejunum or duodenum. So then very difficult to keep the gastric anastomosis, I think. But we only I experienced only 40 or 50 cases about use pancreatic intervention. So still, low experience, I think.
Oh, no, very high experience.
And so the next question is about training for doing EUS pancreatic ductal drainage, because I think it's one of the most skilled procedure for therapeutic EUS. So what is the learning curve for EUS PDD?
Okay, it is also a very important question. So for the training, so I firstly teach the EUS observation, and 50 to 100 cases after the FNA, maybe 15 cases or more. So after that, I teach the EUS BD and pseudocyst drainage, so simultaneously. So because there are many dedicated devices for the EUS BD in Japan, so then recently the EUS BD is not so difficult procedure in Japan with dedicated devices. So, and 5 or more cases, the endoscopic trainee performed the EUS BD. I teach the EUS PD to the trainee. So, and my junior doctors, my junior doctors, four doctors can perform the EUS PD. So they performed 2 or 3 EUS PD and about 10 or 15 EUS BD. So then I think the total interventional EUS 20 or 30 EUS BD or pseudocyst drainage can perform the EUS PD. This is our ordinary teaching process.
As you showed us a lot of videos and a lot of technical issues. I have a technical question for you. You know, in chronic pancreatitis, sometimes it's very difficult to access to the lumen of the pancreatic duct, main pancreatic duct. So, what kind of needle you use to do the approach of the Wirsung duct?
Okay, so needle. So I usually use Olympus EasyShot 3. So previously, I select sonotip needle. It is the most sharp needle. But recently, so Olympus EasyShot 3 is a very good needle with a sharp tip. So, but our tip is so try to penetrate a pancreatic duct. Very extremely hard puncture.
Yeah.
So it is so our equipment.
Because sometimes the pancreatic gland is going away, far away from the stomach, and you are not entering into the Wirsung duct.
Yes. So try to penetrate.
Okay. Like a warrior. Like a Japanese warrior. Okay, but it's really often technical issues, a lot of technical issues for pancreatic ductal drainage.
Yes.
Yes, but we saw that even if you have a great expert in for this topic, there is always 20% of adverse event when we use this kind of pancreatic drainage. So it is always the most technical and the most difficult procedure, I think, for the EUS drainage in our specialty.
Yes. And 20% of adverse events, and of whom 15% are severe adverse events.
Yeah. So we understand that there is no limit for the caliber of main pancreatic duct for you.
So for the maybe a 2 or 3 meter is available with a 19 gauge needle, but sometimes less than 2 millimeter. So at that time, I selected a 22 gauge needle. Previously, only a 021 Cook guide wire available, but recently, so maybe next year you can use the 018 guide wire from Olympus. It is a very good guide wire. So then most of the pancreatic duct, if we can see the pancreatic duct with the EUS, we can puncture, I think.
Wow.
Okay, and just I heard you speaking about your fellows, and you told us that your fellows started at the same time, EUS PDD and pseudocyst drainage?
So EUS BD, biliary drainage and the pseudocyst.
EUS biliary drainage.
Yes, PD is more difficult.
Because EUS PDD is the last to do. Huh?
Yes.
Yes, I agree.
Yes.
Yeah, I agree.
First pseudocyst drainage, then biliary drainage, and then pancreatic ductal drainage. You agree?
Yes.
Yes. Yes. You agree also? Yeah, also. Okay.
Dr. Isayama, I have a question for you.
Yes.
Some of patients have very small pancreatic duct, like pancreas division patient also. How is the success of endoscopic intervention for these patients? I think it's very little success rate for an invasive procedure like endoscopic ultrasonography intervention.
Okay, thank you very much. A very important question. So actually, very difficult. But most important thing is with strong heart. So never give up. So and stabilize the scope and deep sedation the patient, no movement. And I firstly puncture the needle beside the pancreatic duct, and 2 or 3 patient respiration, and so after that, so in best timing, I puncture the duct. So and the 2-step puncture method is available for the thin pancreatic duct, I believe. And the most important thing is that never give up mind.
So we appreciate the movement with your hand like this. Very impressive.
About long-term success rate. For chronic pancreatitis, we know that if pancreatic duct is not dilated, endoscopic treatment success is very low. Not for procedure, after procedure. For long-term success rate, for small diameter duct is very low. For that, I am not sure endoscopic treatment is success if it's required for these patients.
This was the last question.
So,
okay, last comment. Okay, so we have to close this very interesting and fascinating session. And I asked to Prader to close this session. Prader, you want to close it as a moderator? No? Prader has no microphone more. So maybe Geoffroy, you want to close because you have still your microphone open?
Yes, many thanks for this very impressive presentation, especially for this difficult duct drainage under US control. So maybe the most important conclusion is that we need to be an expert in US interventional procedure before to do this kind of technique. But there is clearly a large place, a wide place for this new very interesting interventional procedure. So, Mark, it is always a pleasure to see you.
Yeah, it was a real pleasure, but we're only far from 200 kilometers. So
yes.
Okay, so we are ending this session. So thank you to all the moderators and the two experts. And we move to the next session, the section 4. And I'm pleased to invite the moderator, Professor Majd. Yeah, I don't know if it is a good pronunciation. I apologize. And also Professor Ankit.
Hello. Hi. Yeah.
Hello. Okay. Nice to meet you.
Nice.
And Professor Mostafa Ibrahim. I don't know where it maybe is in the teaching session. So we have 3 presenters. Professor Feliz Accuse. Okay, I apologize again if it is not the good pronunciation. Mrs. Feliz Accuse. You will tell us what is a good pronunciation. After we have myself and Mostafa Ibrahim. Okay. So I leave the place to the moderator now.
Okay. My dear colleagues, after an amazing session, we will start the last session entitled EUS Days 2020 Debate 2. Before starting this session, I would like to thank the organizing committee for this impressive and well-organized meeting. We have 3 speakers who are expert on EUS in this session. The first speaker is Dr. Accuse. She is professor of Department of Gastroenterology, Istanbul Medical Faculty, Istanbul University in Turkey. Dr. Accuse will talk about EUS PD with lumen echo-zinc metallic stents. Dr. Accuse, the microphone is yours, please.
Thanks, Müjde. It's a pleasure to be with you in this webinar. Thanks to the organization committee. We will talk about EUS BD with lumps. The success rate of ERCP is high. However, an underlying neoplastic process, it can be lower and with a higher risk of adverse events. Also, percutaneous biliary drainage can be an alternative method, but again, this has a high rate of procedure-related or drainage-related complications. And also, readmission rate is high at 3rd day. In these conditions, EUS BD may be useful alternative for jaundice palliation. What are the general accepted indications for EUS guided BD? Failed conventional ERCP, most common causes tumor infiltration of papilla and tumor preventing access into the biliary tree. And how about for benign biliary stricture? Successful clinical and technical successful rate reported from experienced centers from Giovannini Center, but however, long-term outcomes are unclear. So we couldn't recommend EUS BD for benign biliary stricture in our routine clinical practice now. What are the contraindications? In fact, there is no clear evidence of contraindication, but if we couldn't visualize bile duct by EUS, intervening vessels and or other organs, or if the patient has coagulopathy, severe coagulopathy, or bleeding tendency, or excessive acids, we shouldn't perform EUS BD in these conditions. We have different type of lamps in market from different countries, and lamps delivery includes traditional multi-step access by 19-gauge needle and or single step. Also novel applications for lamps developed nowadays. What are the approach or access? It can be by intrahepatic or extrahepatic. Generally, we use in clinical practice this terminology: transhepatic, hepaticogastrostomy, and transpapillar antegrade procedure, transduodenal, most common used way, choledochoduodenostomy, and rendezvous procedure. Transpapillar or antegrade drainage have smaller risk of post-procedure bile leak. EUS hepaticogastrostomy is not easy for LAMS, may be difficult or impossible when ducts within the left lobe of the liver are non-dilated. Generally, we use hepaticogastrostomy by plastic stents or covered metal stents. For EUS, transduodenal rendezvous methods is first choice of cases with ERCP failed with accessible papilla, and also sometimes this is not easy method in all patients. If we compare the success rates of these access, you see here easily EUS choledochoduodenostomy has higher technical and clinical success rate. And we shouldn't forget mortality rate is 10% during the initial phase of learning curve. And also we don't have to forget our technical and clinical success rates correlated with our experience. Procedures is selected according to the patient's clinical condition, location of bile duct obstruction, presence of duodenal obstruction, and GI and biliary reconstruction. If we have accessible papilla with distal biliary obstruction, first choice should be choledochoduodenostomy. And if accessible papilla with biliary obstruction and surgical or surgical altered anatomy, again, first choice should be hepaticogastrostomy. And if an inaccessible papilla with duodenal obstruction or surgical anatomy difference, first choledochoduodenostomy and hepaticogastrostomy. In this study, they used electrocotar enhanced lamp for BD, EUS Guided BD, and you see the higher technical and clinical success rate and lower adverse events, especially in early periods and also during the follow-up. In this case series, 44 cases of patients had duodenal stenosis, and also they inserted duodenal stent for the palliation of GI obstruction in the same session. Here you see the video from this article. First, you see the dilated main bile duct from the duodenal valve, and with electrocotar enhanced lamps, first directed puncture in a single step. You will see soon here. And then, yes, puncturing from bulb. And then first open the distal part of lamps and traction of the sheet to the back, and then open the proximal part of lamps. And you will see the whole lamps soon. Here, this is a single step lamps. And also electrocotar enhanced lamps is not useful for the hepaticogastrostomy because complications rates will be higher because of coagulation. And also in this procedure, yes, and it's inserted by single step. And then they inserted duodenal stent by colonoscopy in the same session. Here the endoscopic view of lamps. and then they inserted by colonoscopy through the scope GI stent for the palliation of obstruction. Yes, you see the obstruction and guide wire. And opening of the duodenal stent. Successfully inserted duodenal stent in the same session. Yes. And the most common adverse events was tumoral obstruction within 6 months in this group of patients, and they treated in different ways: percutaneous biliary drainage, gastroscopy plus pigtail, SAMS, surgical derivation, or palliative care. And the main risk factor was cholangiocarcinoma for stent obstruction. In this study, they compared between transpapillar stents and EUS guided stents. In both groups, demographic features were not statistically different. They used hot Axius 6 or 8 millimeter stent. You see only 15 patients is available for USBD lamps in this group of patients. And you see adverse event is very rare in early period, only 2 patients. And all patients has malignancy, and most common preferred access was choledochoduodenostomy. Only in 1 patient, hepaticogastrostomy, and you see here plastic stents were used in this patient. But adverse event rate is higher in USBD group, and also fatality rate is higher in USBD group. So we can say if we have a adverse events in USBD procedure, our fatality can be high. This study concluded USBD is associated with a lower survival rate and a higher rate of fatal adverse event, which argues against its use as a first choice procedure. In this study also reported high success rate for lamps. Most common procedure complications included perforation and bleeding, and another most common complication, stent obstruction. And they treated obstruction with placement of plastic pigtail through the lamps or replacement with a new stent. If we compare the adverse events with between different approach, you see here the higher incidence rate of adverse events was seen in hepaticogastrostomy, bilioma, bile leakage, stent migration, liver hematoma, and sepsis. In this study, also single-stage method used for BD, and most common preferred access was transbulbar, and all patients again had malignancy. The success rate is high, 98%. Adverse event occurred in only 11 patients, bleeding, stent occlusion, and migration. Also in this study, they inserted duodenal stent for the palliation of duodenal obstruction. In this study compared to electrocotter enhanced lamps alone with stent within electrocotter enhanced lamps for the evaluation of late biliary obstruction, and they clearly showed that late biliary obstruction rate is lower in the group of stent within electrocotter enhanced lamps. In this study included huge number of patients. They evaluated long-term outcome, and here 80% successful for ERCP and only 11% of patients available for lamps. And again, here all patients had malignancy. They used single-step Axius stent lamps, and you see they use different type of diameter. and there is no procedure-related adverse event, early adverse event only in 2 patients, cholangitis, and in the long-term period, reintervention because of occlusion, 15%, and other reintervention rate, 31%. If you see this patient, nearly after 2.5 years, he alive, and there is no complication about stents. Most common complications, bleeding, bile leakage, peritonitis, and they concluded novel dedicated lamps is useful for this approach, and the adverse events and patency rates are inferior to the historically stents. You see in different studies, technical and clinical success were similar, but adverse events can be changed. Here, 40% of adverse events were reported. It depends to maybe patient selection or center's experience. And most common complications, again, migration, bleeding, obstruction, and cholangitis. Here, this is the first meta-analysis comparing EUS Guided BD with ERCP Guided BD for primary drainage of malign biliary obstruction. And technical, you see this meta-analysis easily. Technical and clinical success are similar. Pancreatitis rate is higher in ERCP. This is statistically significant. Bile peritonitis rate is higher in, EUS BD, but this is not statistically significant. Stent dysfunction is less in US, and also tumor enrollment is less in US. So with adequate endoscopy expertise, EUS BD could show similar efficacy and safety when compared with ERCP BD for primary palliation of distal main bile duct obstruction and exhibits several clinical advantages. As a summary, expert level endoscopic skill remains a necessity for EUS BD with lamps. The technical complexity and rare opportunity to perform these cases should be limited. Practice should be limited at this time to expert center. Most common adverse events for EUS BD are migration, obstruction, bleeding, and perforation. And also access preference depends to the patient's features, GI anatomy, and most common suitable route is transbulbar. Single stamp lamps is easy and fast. Also, we can insert duodenal stent at the same session for the palliation of GI obstruction. Thank you very much for your patience.
Thank you.
Thank you, Dr. Feliz. That was a wonderful talk. I would like to now invite Dr. Marc Barthet. He is a professor of gastroenterology and hepatology in Marseille to give his talk on EUS challenging ERCP. Over to you, Dr. Barthet.
Okay, thank you very much. So I will try to do this speak. This speak is putting together technique with bile duct drainage, pancreatic ductal drainage, and you will see also some gastroduodenal anastomosis. So it's a way to show how you can do with therapeutic EUS for managing these patients. Okay, so now, as my topic is about EUS challenging EUSCP, we will see failed EUSCP, altered anatomy, difficult stenosis, and EUS is an alternative, a primary alternative to EUSCP, and how rendezvous technique, cholecystectomy, hepatic gastrostomy, and at the end, a very short comparison to percutaneous approach. So, as was taught by the previous speaker, we have a meta-analysis, a huge meta-analysis, more than 1,000 patients, showing that the results of successful transgastric and transduodenal drainage for biliary drainage is more than 90% of the cases, but with a significant morbidity. And this is highlighting the problem of training for bile duct drainage and also pancreatic ductal drainage. We spoke about it in the previous session. of course, this is a multi-center series. So if you look to a single center series, putting together 100 patients, you see also the technical and clinical success of EUS guided biliary drainage was excellent, more than 90% of the cases, but also with 12% of adverse events and 12% of severe adverse events. So again, take care to the training. So what is the exact place of EUS guided drainage in case of failed URC? I want to show you this paper published in Endoscopy. Of course, it's a retrospective series, but it was very interesting. It was including 2 different cohorts, one cohort with native papilla and EUS approach or pre-cut available in case of failed URC, and a patient with only pre-cut available in case of failed URC to have a good comparison with secondary EUS. So the tools used were rendezvous technique, integral placement of transpapillary drainage, and of course, a transmural drainage with hepatovagal gastrostomy. And if you look to this series, you see here the comparison between pre-cut and EUS guided biliary access, and you see clearly that you have a technical success more often in case of EUS approach than in case of pre-cut approach, and also if you include many attempts. If you look to the indication, for biliary stones indication, it was the same between pre-cut and EUS success, but for malignant obstruction, it was significantly better to use EUS approach. So the first message is, if you have any difficulty with URCP in case of malignancy, don't hesitate to switch to EUS approach. This is the first message. And the second message is this one. This one was a Japanese series about failed URCP in you see in 520 URCP and 45 failure, and they compared rescue PTBD or EUS versus primary EUS. And if you look here, now here you have rescue PTBD here, and here you have rescue EUS rescue EUS biliary drainage, and here you had, I don't know if I can displace, okay. And here you have primary EUS biliary drainage, and look to the results. Technical success are nearly the same, okay, and adverse events are not the same. If you look to PTBD, PTBD has major complication, major adverse events compared to rescue or primary EUS drainage. So, in my opinion, and we do that in our hospital, we don't do any more PTBD. We do only EUS approach. Either rescue, either primary, but no more PTBD because the morbidity is very high. And if you look now to the complication, look in rescue EUS drainage, you have pancreatitis. Why? Because you try many attempts for URCP, and in the case of primary EUS, you have biliary leakage. So, in fact, you have to choose between your complications. You have the same rate of complication, but the complications are not the same if you choose rescue EUS or primary EUS. Now, what we can do in alternatomy. Okay, alternatomy can be found in case of Roux and NY gastric bypass, in case of hepatic oliginostomy, or after Whipple procedure. These are the main cases to find alternatomy. So you can use enteroscopy with double or single balloon, but you see the success of the procedure is about 2/3 of the cases, with some adverse events also. So the challenge is, have we to do PTBD, so percutaneous biliary drainage in case of alternatomy? Have we to do enteroscopy, which is called E-enteroscopy for URCP enteroscopy, with a double balloon coming in the efferent limb and going to the hepatico-jejunal anastomosis. Or have we to use EUS approach? We developed the two-step approach. Why two-step approach with EUS? First step is only to put a stent, so to have a reliable fistula between the intrahepatic bile duct and the lumen of the stomach. And the second step is to work through the fistula and to treat stenosis or to treat bile duct stents. And why two-step? Because if you do everything in one step, you have no adhesion between the liver and the stomach, and so you can have a biliary leakage, and it's very dangerous. So my advice is use EUS approach first, and secondly, use a two-step approach. Okay, and here you have an MRI image, a nice image of hepatico-jejunal anastomosis. So we published 4 years ago the first pilot study about this kind of approach with two-step approach. And now we have two different series. One series is a retrospective series with, you see, successful biliary stenting 85% of the cases with transgenual or transgastric access. This one is very interesting. Why? Not because there are more patients, 37 patients, but because they started to do one stage antegrade intervention in 8 cases, and they stopped because they had a lot of biliary peritonitis due to the lack of adhesion between the stomach and the liver. And so after, they delayed the remaining one in 2-step procedures with a clinical success in more than 90% of the cases. And this is a part of our series in 12 patients. And you see, we have always technical success for hepaticostomy, and we crossed the hepatico-jejunal anastomosis in 1/4 of the cases as the first step. And in the second step, and in the remaining group, we do not cross the anastomosis. And after we take back in the second step the patients, and we have okay for the 3 first one. And in this group, we cross the anastomosis in 3 more patients, so half of the group. And after we put back the patient for changing the stent, and we finally cross the anastomosis in 3/4 of the cases. So clinical success were in 100 cases because all the patients were drained with 4.2 endoscopies at mean, and technical success was 75% of the cases. So I show you on this video what we do. This is the second step. You see, we at the first step we put a fully covered metal stent to be retrieved. At the second step, we are into the stomach with a regular scope, and now we are pushing a catheter, a sheath with a guide wire, and now a balloon for making the dilation between the bile duct and the jejunal anastomosis. Okay, and you see it's like a PTBD procedure, but through the gastric wall. So it's less invasive for the patient and less morbid also. And after, over the guide wire, so this is a fistula, you have to push a double pigtail stent. While a double pigtail stent, you will see it on the next video, because you prevent any risk of migration. So in this patient, it was our beginning, there was a straight stent, but you see the migration. This is a jejunum, this is a bile duct, intrahepatic bile duct. So again, balloon, okay, for dilating the anastomosis between the jejunum and the bile duct. And after, we deliver a double pigtail stent. You see, over a long guide wire, this is a 15 centimeter length double pigtail stent. You see, this is the first tail, okay? And you will see this is a distal, of course, in the tooth jejunum, and the proximal will be into the gastric lumen. Okay, so you have no risk of migration, and after you can add as much double pigtail stent you want, because it is 7 French double pigtail stent. So you add the pigtail as much you obtain the dilation of the stenosis. like for any drainage. Now it's another case. It's a very special case. I told you that you can use usual biliary drainage, EUS guided or pancreatic drainage, but this is a biliary drainage through gastrojejuninal anastomosis. It was a patient who underwent pancreatic duodenectomy for malignant net, and after he had the liver metastasis and no more left lobe because it was rejected by the surgeon. So no hepatic gastrostomy was possible. So we decided to do, and I will show you the video. Okay, you see here, we decided to do a gastrojejuninal anastomosis through the gastric wall. Okay, so this is a guide wire. Inside the limb, the anastomotic limb, which was connected to the bile duct. So over the guide wire, we push the hot axial stent, which was a 20 millimeter hot axial stent, inside the jejunum. You see the anastomosis is just there. We deliver the distal flange, and now with endoscopic control, we are going to deliver the proximal flange. Okay, here. You see, when you see the black ring, you can release. Okay, and now you see the gastrojejuninal anastomosis is done. But you have not to try to pass through, because if you do that, you have a high risk. You see the limb going to the biliary anastomosis because you have a risk of dislodgement of the stent. Okay, so because you have no adhesion. So the second step, it was 2 weeks later. You see, we are into the stomach. We go into the antrum. And now you see the proximal flange of the axial stent, which was connected to the jejunum, to the anastomotic limb. Okay, now we are entering with a gastroscope inside. Okay, you see, and we are going to progress through this limb with a small loop. And here we reached the biliary. You see, this is a biliary anastomosis with the jejunum. Okay, we push a guide wire, and after it's like any USCP because it was a metastasis at the hilum of the liver, and we drain with 2 double epithelial stents on the left and on the right the liver of this patient. Okay, so it's an alternative in this case to enteroscopy and also to PTBD. And this, for the patient, is more comfortable, and it's easier also because after when you have to change the stent, it's very easy and very short. You have not to spend more than 1 hour to reach the biliary anastomosis. Okay. So you can treat stenosis, as I showed you, but you can treat also intrahepatic bile duct stents. And I will show you in this patient. Okay, this patient has a completely obstructed hepatico-jejunal anastomosis. So at the second step, we pass with a spyglass through the hepaticogastrostomy into the intrahepatic bile duct of the left lobe, and until we reach the anastomosis. And you see, we had bile duct stents just upstream to the anastomosis, which was completely narrowed. So we used lithotripsy with the fiber inside. You see the tip inside the peritine channel of the spyglass, and then we crush all the bile duct stents. Okay, until we see, and you see no more contrast going inside the jejunum. Okay, and after crushing the stents, we try to find the small communication with the guide wire that directed by the spyglass, and you see it now. Okay, now we go into the jejunum in order to do again the anastomosis between the bile ducts and the jejunum. And so after we let in place the guide wire, and we retrieved the spyglass and the fiber and the catheter, and over the guide wire, we pushed a balloon for making the dilation. You saw the fistula between the stomach and the bile duct, and this is the dilation with the balloon. And after, again, we used a double epithelial stent, a 15 centimeter length, and we put 1 and then 2, 3 until we get a good and reliable dilation of the biliary anastomosis. So you see, you can do many things for the patient with this kind of approach, which is for the patient more comfortable and less invasive. What can we do in case of difficult stenosis? For instance, this was in case of hilar carcinoma. And I show you in this patient after post-cholecystectomy biliary injury with completely transection of the bile duct. So we were at the second step after doing the hepatic ostostomy and with fully covered metal stent. Then we go through the fistula and we push the guide wire, okay, inside, and you see we have a complete obstruction of the CBD. So we decided to drain at this time the left lobe and the right lobe through the same gastric orifice. So this is the first guide wire, and after we have to put the second guide wire into the right lobe, and so we drain both the right lobe until we go with the spyglass after in the remaining CBD, trying to find any passage to the downstream CBD. You see, you have the guide wire into the right lobe and a guide wire into the left lobe, and it's okay. You can drain completely the patient. I will show you quicker. You see the two guide wires, and you see this is the first, the second stent, okay? And you see we have a complete drainage in this patient. Okay, now we can do that also for the pancreatic duct drainage. It was shown by Hiroyuki Izayawa in the previous session. But just to remind you that the technical success is lower than for bile duct drainage, close to 70% of the cases. But the main problem is the complication rate in this case is about 20% of the cases, of whom 15% are major complications. So take care. I think it's the most difficult therapeutic EUS procedure to do, and with higher risk of complication. So I'll show you very quickly. This was a patient with previous pancreatic duodenectomy, and you see with recurrent attack of acute pancreatitis. This is a pancreatic duct, which is a dilated pancreatic duct, and for me, you need at least 5 to 6 millimeter dilation to try to do pancreatic ductal drainage. This is a 19-gauge needle. So you have to be clearly in the axis of the dilated pancreatic duct and push very strongly. You see with X-ray the contrast inside the remaining pancreatic duct. And now we are trying to push, and you see the guide wire. I thought I was into the peritoneum. In fact, the guide wire went through the pancreatico-gastric anastomosis, and you can see it now. You see, okay. Into the gastric lumen. So we decided to put a double PTL stent, like for rendezvous, a special rendezvous technique. And so one was through the surgical anastomosis, and one was through the EUS anastomosis. Okay. Now, if you compare to enteroscopy for pancreatic ductal drainage, and you see the technical success and clinical success of enteroscopy for pancreatic ductal drainage when the surgeon do pancreatico-genuine anastomosis, you see it's very weak, 20% of the cases. Of course, more adverse events because the technical success was important. And again, you have at least 20% of complication. And now, is primary EUS an alternative to URCP in normal anatomy? So the question is, so you are facing with a patient with difficult URCP, cholangitis, malignant obstruction of the common bile duct. Do you use EUS first or URCP? We have 3 randomized series, including 222 patients for distal biliary obstruction. And look to the different series. The first one, including more than 60 patients in each group, you see there was no difference for technical success, clinical success, adverse events, and the quality of life seems to be better with EUS. But there was, of course, more pancreatitis in the USCP group. But 14% of pancreatitis for USCP is too much. Usually it's about 5% of the cases, so it's too much. But clearly, EUS can be thought to be an alternative, primary EUS to be an alternative to USCP. Now look to this one. This one included very few patients in each group, and no difference between technical, clinical success and adverse events. But of course, if you have only 15 patients, of course, it's very difficult to show any difference. And the third one was including 30 patients in group with comparable technical success, clinical success, and adverse events. But the need for reintervention was higher with USCP, clearly higher, even if it was not significant, due, I think, to the weak number of patients included. And if you look to this meta-analysis performed with the 3 randomized series, you see the technical success, the clinical success, and adverse events were the same, not significantly different, but there were a lower rate with EUS of stent dysfunction requiring further intervention. So we can say maybe it was recommended to use EUS for primary drainage. I don't believe that, because it's a very skilled, it's a skillless procedure, but we can discuss about it. How you can challenge USCP with EUS, rendezvous technique, choledochoduostomy, and hepatogorsostomy. So you saw with the previous speaker, and I thank her for his excellent presentation, different way. I just want to show you very briefly some videos. This is hepatogorsostomy. Okay, we are usually we are targeting the segment 2. You see through the stomach. We are very high in the stomach, usually under the esogastric junction, 5 centimeters under. And you see you push, you use, of course, 19 gauge needle, you push the guide wire, and this patient has duodenal stenosis and biliary obstruction. And we decided to push a stent between the stomach and the liver, because the stenosis was so high, it was not possible to push. And if I push more, I had the risk to have a biliary leakage between the stomach and the liver. So I choose to do, to be cautious, I choose to do the 2-step procedure, and using hepatogorsostomy in one step and then 2 steps. Now I show you choledochoduostomy. I think you need at least 10 millimeter diameter to use. This is a portal vein. This is you see a portitis due to the pancreatic carcinoma, and you have to check carefully all the vessels. And after you need at least 10 millimeter diameter to be safe. And I use LAMS stent. You have to take care also of the cystico choledochus confluence, not going into the cystic duct. And I use direct approach, but with a preloaded guide wire. And after, as soon as I am inside, I push the guide wire to be safe. Okay? Because if you have any trouble, after you have the guide wire and you can push anything over the guide wire. After you release the distal flange, and after under endoscopic control, always you see the black ring, and after you release the proximal flange inside the bulb lumen. And it's okay. And if it is okay, if you are sure of the quality of your drainage, you can release the guide wire. You see, we have still the guide wire. So if you have any trouble, we are able to retrieve to do another drainage. And I will show you an example of a complication and a rescue procedure. This was, you see, a huge dilation of the command of the CBD, okay, with the cystic duct here, not going into the cystic duct. So it was okay for this patient. You see the guide wire, you see the axial stent inside the lumen. Okay, so we start to release. And after we had the technical problem because we have no more insufflation. I don't know what happened, but it was my fellow was working, and we had no more insufflation. We didn't see anything, and finally he retrieved everything, the stent and the guide wire. And you see, the proximal flange was between the bile duct and the duodenum. Finally, we succeeded by pushing the guide wire inside the hole, and we came again into the bile duct, and we had through the axial stent a regular, completely covered stent, which was crossing the axial stent, of whom the proximal flange was located between the duodenal wall and the choledochus. Okay, so this was a rescue study, so a rescue case. So as you know, the success rate and complication rate are well known for intrahepatic drainage or choledochoduostomy with the same rate. Look to the success rate of rendezvous technique, but rendezvous technique is not so simple because here is a rendezvous technique I did in Paris, but you have to push very far from the papilla the guide wire, because if not, when you are using the second scope, you have the risk of losing the guide wire because you are making a loop over the greater curve of the stomach and you are pulling back a little bit the guide wire. So push as much you can the guide wire into the duodenal lumen, and after you catch the guide wire with the snare, but not on the hydrophilic part because you can break it, but on the strong part of the guide wire. And you see it works a lot. This was a comparison between choledochoduostomy and hepatic gastroscopy, and you see it was the same rate for efficacy and the same rate for complications. So there was no difference between hepatic gastroscopy and choledochoduostomy. It's a question of dilation of the bile duct and also of use. This was a comparison, Brazilian comparison, prospectively done between hepatic gastroscopy and choledochoduostomy, and you see the number was the same in each group, and the clinical success and complication was the clinical success was better for hepatic gastroscopy, but the rate of complication was higher with hepatic gastroscopy. Just I finished my lecture just with some data about comparison with PTBD. We did in Marseille this randomized control series comparing PTBD and EUS. It was the same rate for technical access and clinical efficacy, but the complication rate was much more frequent in PTBDs than in EUS. In this small series, there was a better efficacy of PTBD and a similar adverse events and mortality. But it was a small Canadian series. And if you look to this meta-analysis done by Sharia in US, the meta-analysis showed in 9 studies that EUS and PTBD had similar technical success, but better clinical success of EUS, of course, because it's more comfortable for the patient, fewer adverse events, and also less reintervention rate and better cost efficacy. So I think you have to do as more you can to do EUS approach compared to PTBD. And for me, also EUS approach compared to enteroscopy in case of alternatum. So EUS, biliary, and pancreatic ductal drainage are still complex technique, but devices are really improving. So choose the good devices. There are a lot of technical issues. I have no time to speak about. You need 2 or 3 hours to speak about it, but take care. And education and training could be a challenge. And we are actually producing a new animal, ex vivo animal model to train our fellow to EUS guided hepatic gastroscopy. So thank you for attention.
Thank you, Professor Bartek. That was an excellent lecture. So are we going live, or are we going to take some questions now? Is Professor Mustafa ready with his hands-on for the pancreatic cyst drainage?
Yes, I'm ready. I think you can, if you can hear me and you can see me. Okay, so welcome again to the hands-on part. So now I'm doing in this session EUS cyst drainage, cyst gastrostomy. So I'm using again the Fujifilm scope, the 580 UT with the SU1. And today I will show, just if you can, the camera can focus in this part first. You can see this is how it was before. So if I would like to really to drain a cyst, I will do EUS gauge needle, 19 gauge needle. I will puncture, and then either balloon dilatation or thermal dilatation by cystotome using a guide wire, and then a pigtail stent, and then maybe dilatation and putting another guide wire and a second pigtail. So again, this is the standard of care. This had been always the standard of care. On the other side, the paradigm shift happened a couple of years ago when this device has been introduced to the market. This is the hot axis needle. This is the Boston Scientific hot axis needle. And as you all know, it's a one-step technique. You have everything inside. You have the lamps inside, you have the lumen apposition metallic stent inside, and you have the tip, which is connected to the electrosurgical unit. I'm here today. I'm using the new BUVA, really a state-of-the-art device, the new BUVA ARC 350 from BUVA company. And again, it's a one-step technique. You can puncture, release the stent, and drain the cyst. There's two techniques. One of them is the freehand technique, which I will use it today, which means that I can puncture without having a guide wire inside. And also there is the other one that we can use it on a guide wire, which means you can puncture by a 19 gauge needle, and then you exchange and you put it on the guide wire. But what I'm going to show you today is the freehand technique. So you can see now a little movie for the Axios. I will prepare myself. So I will fix my stent in the scope. So you need only a linear EOS scope, and you can see here that you fix it by just turning this. So now it's fixed. So now it's only, I don't need any assistance. Yes, I would love to have my assistants with me, but on the other side, I don't need anyone. So I can do everything by hand. So if you can show the EOS image, please. So this is, I'm using again one of my babies, one of my simulators for the cyst drainage. You can see a very big collection here. And the idea that to put and to drain this drainage. So first of all, I will position myself. If the camera can focus in this part, you have everything here really written. You have 1, 2, 3, 4. It's a 4 steps technique. First one of them, I will unlock this part, and then I will push my sheath, my external sheath. I will open the elevator a little bit. You can see on the EOS image. Can you make it bigger, the EOS image, please? Yes, very good. You can see. So this is my tip of the stent, like this. And now I will connect the BUVA machine. And then first step, I will puncture the cyst just like this. So I'm inside. This is number 1. Then second step, I'm sure that I'm inside. I will lock again the lock to make sure that I'm not. No, keep the EOS image bigger, please. Okay. And now I will. Could you put the EOS image bigger one? Yes, please. Thank you. And then I will. Number 2, I will unlock second step. I will just simply pull this back. You can concentrate on the EOS image. Now I'm opening the distal flange of the stent. And then I stop. I will unlock again this. I will push a little bit to show you. You can see I will just make a better picture here. Like this. You can see now this is the distal flange. I'm moving the distal flange inside. So I have opened the distal flange inside the cyst. Now I will pull back a little bit to make it, you can see it on the EUS image, to make it very proximal to the scope. Now I will ask, please, the control room to give me the endoscopic view. So yes, I will just like this. Yes, thank you. So you have the endoscopic view now. So now I will push a little bit my stent. You can see now I will just make it, I will come back a little bit like this, inflate a little bit. Yes, you can see now on the endoscopic view this black mark. Okay, so this black mark means that okay, I have already pierced it. I have Nuran, if you can put no, do nothing. Okay, I will now open the last part, which is the distal flange of the stent, like this. Very slowly, pull a little bit back. Yes. So now you can see I have released the proximal part. So this is the proximal part of the stent. If you can show Nuran again the EUS view. You see, this is the EUS, this is the distal part inside the cyst. And endoscopic view, please. Yes, and this is the one. So I think this is a very I would say short demonstration how to insert a hot axis stent. Again, there is many other different techniques. One of them, here I'm not using an X-ray because we are using an ex vivo model, but in patients, we can use, again, X-ray to have the control, but you can see it here. It's very easy, really, to do it under ultrasound control and endoscopic control. And you don't need, I didn't use a guide wire. I just used the free technique. So this was a demonstration for how to really deploy a hot axis stent. Again, I think this is one of the future techniques we are going to use. I'm using this and more nowadays, especially in world of necrosis, in complication, post-surgical complications, collections. So I think this is one of the very promising techniques can be shown. So I'm ready for any question if there are from the chairperson.
Thank you for that demonstration, Dr. Mustafa. What do you think about releasing the proximal flange within the scope? I think the question can be answered by the other speakers as well, Professor Parthe and
sure.
Phyllis. Dr. Parthe, you are.
I use the microphone now. You hear me? Okay.
Yeah.
Just
yes.
Very dangerous to release the proximal flange blindly, because you have the risk of dislodging the stent and pushing the stent into the cyst cavity. So for me, the only way to work with LAM stent is to have the last step for releasing the proximal flange endoscopically done. So you have to have, as Mustafa showed us, you have to see the black ring, and when you see the black ring, you can release it, but not blindly, yes. Because I saw many experts pushing the LAM stent into the pseudocyst, into the lumen of the pseudocyst, because they were acting blindly. So I think it's too dangerous. So do it always.
I think yes. This is very good comment from Professor Parthe. This is typically what I do. When I open the distal flange, I will shift totally from my EUS image to the endoscopic image, and then I will rely totally on the endoscopic image in the last part. So when I see this black mark, I always open the distal part, the distal few millimeter of the stent, even inside the working channel. And then I push, after being open, I push everything with the catheter to make sure, because I have seen it once. I have seen, as Professor Barthe was saying, I have seen it once that the stent was released inside the cyst, which is not I think the best thing. So this is why I always release the distal part under endoscopic view.
Fully agree. I fully agree. I have another comment about, so the technical issue was perfect with you, Mostafa. Congratulations, because it was very didactic. I've just a comment about indication of LAM stent. Don't use a LAM stent for pseudocyst or cyst, pancreatic cyst, complicating chronic pancreatitis, for two reasons. The first one, you have a huge risk of bleeding at 1 week, at one month. So first, the morbidity is not zero, but you have a 15% risk of bleeding at 1 month. So take care. So you are obliged to retrieve after the stent, the metal stent, at 1 month, and to replace it by double PTL stent. So
I will, Professor Barthe, I will show you while you are talking. Just describing, I will show exactly what you have said, that how to remove this. This is very important. So I'm removing now, as exactly Professor Barthe was saying, that if I would like to remove this, really it's very easy. So I'm using a forceps, which is a big one. And then I will catch endoscopically the tip, yes, close. And then this is to be confirmed after under fluoroscopic control, but I will fix by my hand here, like any tool, I will fix the forceps by my fingers. I will pull everything very slowly, and then very slowly, and then you can see you have the stent here outside, so you have the stent outside. So this is how to remove it, and then I will leave back the discussion for Professor Barthe.
Always at 1 month, at maximum, because at 1 month you have a risk of bleeding of 15% of the cases, sometimes huge and very severe bleeding. So due to erosion of adjacent vessels. So if you use lamps at 1 month, you do a CT scan, and after you retrieve the stent and you exchange with double PTL stent. And the second reason for not using it in first intention for chronic pancreatitis is usually you have a pancreatic ductal leakage. And so after, if you retrieve the metal stent without putting a double PTL stent for a very long time, more than 6 months, as it was shown by Jacques Delière, you have a risk of recurrence of the pseudocyst. So the indication of LAMS for pancreatic colections is wall of pancreatic necrosis, okay, and pancreatic pseudocyst double PTL stent. For
yes, okay. So I will just leave the discussion for the chairperson. So before we stop the transmission here from our side. So I would like to thank you, all of you. Really, it was a great day. So I think this is everything exceeded my expectations. So thank you for all the professors. Special thank to Professor Barthe, the president of EUS Days, and to our sponsors, Fujifilm, Boston Scientific, and Bova. So I would like to thank everyone, and I will leave the discussion with the chairperson. And also I would like to thank really great experts from all over the world. This had never been done. So we have experts from Singapore, India, Japan, US, Europe, on the same time, from all the worldwide, from all the zones. So thank you very much. And I will leave the discussion with the chairperson, Professor Barthe. Thank you.
Thank you.
Thank you. So there are a couple of questions about the duration of lamps and whether you would always put a double pigtail stent inside the lamps after a cyst drainage or a walled off necrosis drainage.
Okay, so I don't let in place any double pigtail stent inside of the lamps, because in fact it doesn't prevent further bleeding. Sometimes it prevents food infection, but not bleeding. So the way I follow is at 1 month I do a CT scan. Either I have no more collection or the collection decreased significantly, I retrieve the lamps and I push two double pit stents to replace the lamps. Either we have collection, I check endoscopically that I have no ulceration of the gastric wall or inside the nephrolectomy, and so I can let in place the lamps for 1 month more.
Okay.
But I don't use at the same time lamps and double pit stent.
Okay.
But you were speaking about pseudocyst or about biliary drainage?
Pseudocyst.
Oh, pseudocyst, okay.
Or walled off necrosis.
So is it clear for pseudocyst? I think it's clear.
Yeah, I have a question for Mark Bennett. Do you still use plastic stent for non-infected pseudocyst drainage in your daily practice?
For non-infected, you mean? Infected or non-infected? I didn't.
Non-infected. Non-infected pseudocyst or?
I use double pit stent.
Double.
For infected or necrotic, I use lamps.
Thanks. And
of course, we have to mind about the cost efficacy, because lamps are very expensive. I don't know in your country, but in Europe, for instance, it's about 3,000 euros. So it's a lot. If you compare to double pit stent, which is 150 euros, it's much less with double pit stent, of course.
Okay, for infected pseudocyst or one, I have a question, another question. Do you use hydrogen peroxide or antibiotic for washing the cyst?
So I use, of course, antibiotics, but in fact, the problem with antibiotics, they are not coming inside the lumen of the pseudocyst, because the lumen is not vascularized. So if you have infected, you put a nasal drainage catheter inside the cyst after releasing the lamp. So the strategy is, as you use the lamps with a guide wire. You push your guide wire, you release the lamps. After you retrieve the inner catheter, leaving in place the guide wire into the lumen of the cyst, and over the guide wire, you push a nasocystic drainage catheter. And you rinse for 1 week.
There are some questions from audience for Dr. Akyüz. One of them is that for EUS BD in patients with duodenal obstruction, do you place a pigtail through the lamps to prevent sometimes syndrome?
Alors, this is a good question. It depends of the diameter of the bile duct, obstructive bile duct. If it is not a large diameter, between 10 to 12 millimeter, it's better to put a double pit stent. Why? Because you will have some syndrome, and so you will have antisusception of the biliary mucosa inside the lamps. So you have a new obstruction of the lumen of the lamps. So in such a case, when you have not so much dilated bile duct, I mean 10 to 13 millimeter, it's better to put a double pit stent. If not, if it is very large dilated bile duct, it's not useful. This is also a reason for why always when you use the lamps, you push after guide wire. Because if you have any dislodgement, or if you have to push to insert a nasocystic drainage catheter, or if you have to insert a double pit stent, you have the guide wire in place.
Another question from audience is acetyl salicylic acid or non-steroid anti-inflammatory drugs should be discontinued before FNA of cystic lesion. What is your opinion?
No, usually when I'm doing FNA in a normal FNA or FNB in a normal pancreatic gland, I am using NSAIDs like for USCP with diclofenac, rectal diclofenac, to prevent pancreatitis. You know the morbidity rate of FNA and FNB is very, very low. It's about 1% of the cases. But if you are doing FNA or FNB in a patient with previous attack of recurrent pancreatitis, it's better to use NSAID like for USCP to prevent pancreatitis. Have you any more questions? We have some questions from the assistant. I think we try to answer. What is the maximum duration you can keep the lamps? 1 month. No more. I mean for pseudocyst, for wall-off pancreatic necrosis. But for gastroesophageal anastomosis, for instance, you can keep it for 3 to 6 months without any problem. For bile duct drainage, also no problem. You can keep it for 3 months without any problem. Okay, I think we answered to all the questions.
If there is pancreatitis and peripancreatitis, is it possible to puncture or wait until inflammation improves?
Sorry, I didn't hear your question.
This question is from audience. Questions like that. If there is pancreatitis and peripancreatitis.
Ah, yes. If it is possible to
puncture or wait until inflammation improves.
Yeah, it depends of the thickness of the inflammation. Because so the consequence is the distance between the target and the gastric lumen or the duodenal lumen. I mean the bile duct, I mean the pancreatic cyst. So if you are more than 1 centimeter, you have not to try to use the lamps. Why? Because you saw the length of the cylinder between the two flanges is 10 millimeter. So if the distance between the lumen of the stomach and the lumen of the bile duct or the lumen of the pseudocyst is more than 10 millimeter, you will have a dislodgement of the stent. So you have to measure with EUS approach the distance between the target and the gastric or duodenal lumen. If it is more than 10 millimeter, don't try to use any lamps because you will have a dislodgement. It's due to the structure of the lamps.
I think there's one more question about accessing the pancreatic duct. So what are the tips to dilate the tract before pushing in a stent?
The question is about to access the pancreatic duct. So in fact, it's a really technical issue because sometimes it's very difficult first to pass through the pancreatic gland and the pancreatic duct with the 19-gauge needle. Because sometimes you have a lot of fibrosis, you have some calcification, and sometimes it's very difficult. So you have to push very strongly and firmly the 19-gauge. Then when you are inside, you push some contrast to be sure, okay, I am into the lumen of the pancreatic duct, and after you push the guide wire. Normally I use a regular Jaguar 3-5 inches guide wire from Boston. It's a Jaguar. This is my favorite guide wire for doing that. I don't try to use a stiff guide wire because with a stiff guide wire you push away the pancreatic gland, and so you increase the distance between the pancreas and the stomach. And after it will be very difficult to push the stent over the guide wire. So use the regular guide wire and take care because you have to push very slowly the stent. I'm not using, after inserting the guide wire, I'm not using any balloon dilator. I'm just using a 6 French cystostom. Why? Because you have not to push very much. So you use with pure cutting current, a 6 French cystostom, and you burn the gastric wall and the pancreatic gland and the entrance into the pancreatic ductal system. And after, it's okay for pushing a 7 French stent. And after when you have the fistula, it's okay. So I'm using 19-gauge needle. I'm using guide wire, regular guide wire, 35 inches guide wire. Thirdly, I'm using a 6 French cystostom with pure cutting current. And after, I'm using a straight stent, 7 French. No more, because you will have a huge resistance and you have the risk of losing the guide wire. And if you lose the guide wire, it's a disaster because you have a hole into the pancreas and you have a hole into the stomach. So after, you will have a pancreatic effusion into the peritoneum. But you know, we spoke about it for training. It's the most, for me, it's most difficult and most dangerous therapeutic EUS we know. For training, you have first to start with pseudo-C drainage, then bile duct drainage with dilated bile duct drainage, and then pancreatic ductal drainage, and then gastroduodenal anastomosis. Okay, I think we have a curve like this to be able to do therapeutic EUS. The major problem is since now we had a lack for a training model. And now you saw the model of Mostafa for doing pseudo-C drainage EUS guided. Now we developed a model for intrahepatic bile duct drainage, like hepaticogastrostomy. We are developing for pancreatic ductal drainage, and for gastroduodenal anastomosis, it's more complicated.
Another question, how long is the learning curve for the EUS hepaticogastrostomy and the use of lamps?
Normally, the EUS learning curve is ranging between 30 to 50 cases, okay? But it means that you have to be trained with ex vivo animal model before.
Thank you. I have a question for you. When you use plastic stent for cystogastrostomy, what's the size of the balloon that you use for dilatation?
Excellent question. So my technique for doing that is not to use any balloon for making dilation. I do a puncture with EUS guided with a 19-gauge needle. I push a guide wire inside the lumen of pseudocyst, and I make 1 to 2 loops inside. After I retrieve the needle, and after I push over the guide wire, a 10 French cystostom, not a 6 French cystostom. 6 French cystostom is for ductal drainage. 10 French cystostom is for pseudo-C drainage. And after you do the coagulation with pure cutting current, and you come into the cyst, and after I use 2 double pigtail stent, because with the 10 French cystostom you can push two guide wires inside. So after, when you retrieve the 10 French cystostom, you have the 2 guide wires into the pseudocyst, and after you push 2 7 French stents, double pigtail stent. And what is important is not the diameter of the stent, it is the space between the 2 stents. So after burning, you have a necrosis and you have a huge orifice. So I'm not using any balloon, I'm just using, and it's very quick, I'm just using the 10 French cystostom over guide wire. After I add the second guide wire, I retrieve the 10 French cystostom and I push 2 double pigtail stents.
Thank you.
But if you want, you can add the dilation after making the orifice with the 10 French cystostom, but in fact, it's not useful. And again, the diameter of the stent is not so important, because what is important is to have a space between the 2 stents. Because even if you put 10 French stent, it will be blocked by the food, by anything into the stomach.
Okay, thank you. Another question related with previous question. You mentioned the training models for EUS hepaticogastrostomy. Yeah. And the question is that, are these training models for purchase? For purchase.
I don't understand for purchase. What is for training? I don't, yeah, I think you cut your microphone. This is the reason.
We need to pay
yeah.
something for training models.
Okay, I just explained the model. The model is an ex vivo model. It's not done in live pigs. It's ex vivo model. We use the liver of a pig with esophagus and stomach. And we add some part of the jejunum close at the two tips and filled with some gel and attached to the liver. And so when you see with EUS approach, it looks like as if you had a bile duct and intrahepatic dilated bile duct. It's an ex vivo model.
As I see, there is no other question from audience.
Okay, so I think we are reaching the end of the last session. So no more questions, so it's perfect. Maybe you have your own questions, no? No?
No. No.
Okay, so I want to thank all of you. Dr. Feliz, thank you very much.
Thank you very much.
Okay, so what is the pronunciation of your first name? Mujde?
Okay. Mujde.
Mujde?
Yes, Mujde.
Mujde. Okay, so I want to thank everyone. I want to thank you, REA organization, all the sponsors, and of course, all the attendees. It's terrible because we cannot hear them, we cannot see them, but they have to know that we think a lot about them, and we try to do a didactic session and to provide them technical information and medical useful information. So thanks again, and special thanks to Mostafa Ibrahim and Eba, who are working a lot, and Marwan, who are working a lot about just behind the laptop to help to this didactic sessions. So thanks to everyone, and I hope seeing you maybe in vivo in some time.
We hope.
The end of the COVID to meet you. Okay.
Thank you.
So,
thank you.
Bye bye, and see you soon. Bye bye.
Bye. Bye.
Bye bye.
Bye.